I'll count you down. 3, 2, 1.
Thank you. Good afternoon and welcome everyone. I would like to call the public hearing of the Aging Committee to order today, March the 8th. Before we begin, I would like to give my co-chair, Representative Garibay, and the ranking members, Representative Wilson, as well as Senator Fazio, who had another meeting that he has to attend, so he will be joining us later. But give them an opportunity for opening remarks. Representative Garibay.
Thank you, Senator Miller. Welcome everyone. I'm looking forward to the discussion and hearing people's voices today. I don't know if she's on yet, but we do have a new member of the AG committee. Miriam Khan was sworn in yesterday. We also have Rep McGee, but having 2 new members, I'm excited. Thank you.
Thank you, Representative Garibay. Representative Wilson.
Thank you, Madam Chair. It's always good to be doing the work on the Aging Committee, and look forward to hearing what the good folks signed up to testify have to tell us.
All right, thank you. And Senator Fazio, you were able to make it, sir. Good afternoon. Would you have any opening remarks?
Good afternoon, Chair Miller. Just that I'm very eager to hear what the public has to say and how we can work together to protect the well-being of older adults in Connecticut.
Thank you, sir. So welcome everyone. I would like to again welcome you here. And as my colleague stated, public hearings about hearing the voice of the public. And so we have policy today, and I know I've received numerous emails regarding the policies. And so those individuals will be here today to express their concerns, whether they support what will be brought forth today or heard today, or whether they, oppose it. But at any rate, we get to hear the voices of the people. So again, I want to thank everyone. And before we get started, I just want to go over a few procedural things, namely that the hearing will be conducted slowly because we're live streaming. And so it'll be a little slower than it would be if we were in person. The first hour of testimony will be reserved for legislators and public agencies, state agencies, I should state, and be followed by members of the public. Now, in the case we don't finish all of the public officials within the first hour, we will alternate between the 2 lists, the list for the public and the list of legislators and state agencies. Please limit your comments to 3 minutes, followed by questions from our members. We have our clerk, Cameron Clark, which we couldn't do any of this without. He will be our timekeeper. Members will be limited to 2 remarks because we want to give every member on the committee an opportunity to speak. So you will be limited to 2 remarks. And after we've given other members an opportunity to speak, then I will come back to you and you can continue your questions. Please do not use the chat function, which should be turned off. And all members, please mute your microphones until you're ready to speak. And then, as you know, please raise your virtual hand so that we'll know that you would like to speak, and please wait to be called on. So let's get started with our first speaker. We'll call Representative, there you are, Representative McCarty. How are you today, madam?
Good morning or good afternoon, Senator Miller. Thank you so much. Good afternoon, chairs Miller and Garibay and ranking members Wilson and Fazio and the members of the Aging Committee. Thank you so much for this opportunity to testify today in support of Raise Bill 5311, an act encouraging socialization for nursing home residents by providing transportation for visits with family. You do have my written testimony, so I will just speak to you about the bill. I'd like to cover some of the aspects of the bill to start with its intent. First of all, the bill means to increase socialization and opportunities for non-ambulatory residents in nursing homes. That's the major intent of the bill. We know that the social emotional well-being of the residents is so important. I mean, I would put it really at the same level as a medical purposes, and also that these are the rights of individuals. You know, the nursing home residents have personal rights, and it goes along with keeping this person-centered approach. So let me tell you why I believe there's a gap here. This is already occurring for residents that may be ambulatory, but if you're non-ambulatory, you don't have those same rights. The family members can't put you in the vehicles to bring you home. So I believe this is also an equity issue, that if you're non-ambulatory, you don't have those same rights. It's not that we need to change the statute, because the statute already allows for this to occur, but it's not occurring because there's just not the means. The part of the issue is the Medicaid reimbursement is not there for transportation for non-ambulatory residents. So I would ask this committee to look at possibly finding a solution for these residents. And, you know, I've been in front of the committee over the years, and this has been something that's really been one of my top priorities, because I've lived it with my own mother that was in a nursing home, and there was absolutely no way for her to leave the facility without, I ended up finding, I was very fortunate to find a hydraulic lift van that I purchased. So I was able to bring my mother home to visit with the family. I think it's so important. I did put in my testimony, if you looked at the Mathematica report during the pandemic, pointed out the really high need to maintain socialization, even with the restrictions that were in place. So we learned quite a bit that we need to keep these individuals healthy on a social and emotional level, as well as all their medical needs. Now, there are provisions in place in the bill that would ask for the physician's authority to allow the individual to leave the nursing home. So that's already in place. We've worked on this over the years to try. And by the way, almost all the administrators, and you'll hear from Matt Barrett a little later, they're all supportive of this bill proposal going forward. You can ask more detailed questions of them. I'm not an expert on the Medicaid reimbursement piece, but I think that's the big issue going forward that we will need to look at. In the meantime, I think offering a small grant for these individuals to use that the nursing homes would have, they're all in agreement, but I'm not trying to put more mandates on the nursing homes. I know we have issues there that we need to look at their funding sources and staffing. I do not see this being a big issue requiring staffing, and maybe Mairead can talk to you later about that. Some of the family members could help get the individual prepared to go visit the home. So I'm hoping the Aging Committee will look at this and move it forward so that we can really address these concerns for the non-ambulatory patient. It will give them hope, if that nothing, that they would have some way of leaving the facility to visit their family members. So, and Senator Miller, I'd like to thank you also. I know you have been very responsive and care so much about everyone that's aging. So thank you.
Thank you, Madam. And we appreciate you bringing the issue to the Aging Committee. You know, I remember when I was in college and I had taken a sociology course, and one of the things that the professor said was that socialization is very important to our society. And that has not changed. We know that is important for our children. Socialization is important to our children, and it's important to seniors as well. I should say the older adults as well. And I know just in my journey here locally, I could see how our aging population have aged since COVID, because they're not having that interaction. There's no socialization there. So I appreciate your advocacy. Because of you, we also had the virtual visitations. So I appreciate appreciate your advocacy in making sure that our senior, older population, our aging population, that they are taken care of and they do have hope. I don't think your hope should ever go away until you leave this earth. And so again, I say this time and time again, we fall short in this country when it comes to taking care of our aging population. So again, thank you very, very much. Are there questions from the members? Comments? I'm sorry, Representative Wilson, I didn't see your hand, sir. You have the floor.
That's perfectly okay, Senator Miller. Thank you very much. And Kathleen, thank you so much for coming before us again. I know you've advocated for this legislation now for a number of years. And I'm just wondering if you felt that if there was one impediment that might be holding this up, because you've tried to bring this forward so many times, what do you feel the major impediment is that this bill doesn't seem to go forward?
Well, thank you very much, Representative Wilson, for the question. I think, no, let me add some remarks to the bill. First of all, that not every nursing home has a van. So if I had my way, we would also expand this with the grant funding, that the nursing home would have the extra funding so they could almost contract out to get the vans to bring these individuals. I don't think we're talking about a huge number, but I think part of the impediment has been that, one, some nursing homes don't have the vans, but they're also very stretched right now for their own resources. And we need to do more to look at the Medicaid reimbursement and what we can do to help our nursing home. You know, we're moving the aging as much as possible with to the home-based services, but I think there will always be a need for quality nursing home services as well, but they're stretched. So while I think they all agree with the goal of the bill and they want to see these individuals be able to go home for social visits, they also feel that they would need the support of the state to do so. So that's why I thought this time we'll try a grant approach to see if that couldn't help, because I really think that we are creating a inequitable situation, and it's, I think it's not fair. These individuals that can't get in a car, you know, to go home with their family, they should not be deprived of that socialization. So to answer your question, I think it's the will is there, it's just the means is not there. Thank you, Representative Wilson.
Thank you, Representative McCarty, and I will look forward this afternoon to hopefully hearing from others who are going to advocate for this and support it. Thank you so much. Thank you, Madam Chair.
Thank you.
Thank you, sir. Are there other questions? Seeing none, thank you, Representative McCarty, for joining us today, and also thank you for your strong advocacy for our aging population.
And thank you, Senator Miller. It's always so good to see you. Good luck for the rest of the day.
Thank you, madam.
Thank you.
Next on our list, we have Murad Painter. Murad, good afternoon. How are you?
Very well, thank you. Good afternoon, Senator Miller, Representative Garibay, Ranking Member Senator Fazio, and Representative Wilson, as well as the distinguished members of the Aging Committee. I'm Murad Painter, the State Long-Term Care Ombudsman, and it's my responsibility to facilitate public comment and represent the interest of residents living in nursing homes, residential care homes, and managed residential communities. I'd like to testify before you today on several bills. The first bill is HB 5310, an act requiring nursing facilities to spend at least 90% of Medicaid funding provided by the state on direct care. I'm in support of this bill, as the need for accountability regarding Medicaid dollars going to nursing homes is incredibly important. It is critical that we prioritize the care and services for residents and their quality of life. This can't be achieved when large portions of the funding coming into the building is spent on management and other fees that don't directly support the residents' well-being. The requirements in this bill also ensure that care team members who are directly interacting and supporting residents will receive appropriate pay for the work that they do. I believe that this will increase the numbers of individuals who work in these roles, ensuring that adequate staff is available. This is necessary to provide appropriate
This is David Wilson.
burnout and prevent injuries among staff and residents. We hear about nursing homes not being profitable. However, when you dig a little deeper, you'll see that the lower profit margins at nursing homes translate into higher profit margins with parent companies, holding companies, and other companies related to the nursing homes. For example, real estate, companies providing services to the nursing home that might retain income, or even profit as a nursing home appears to be less profitable. Requiring that 90% of the Medicaid funding go to direct care will result in residents having the opportunity to reach their primary goal and have the care and services, not profit margins. Next bill is HB 5311, an act encouraging socialization for nursing home residents by providing transportation for visits with family. We support this bill and believe that any opportunity a resident can have to spend time with family or a loved one will benefit their overall well-being and should be a right that is respected. Access to community integration is so challenging, and if there is a grant in place that would allow for this without it also burdening the nursing home, we absolutely support it. The next bill is HB 5313, an act concerning temporary price controls on services provided by temporary nursing service agencies. I support this requirement. One, the temporary nursing services agencies register with the Department of Public Health, and two, that the Department of Social Services set a maximum rate for such services provided in nursing homes. The registration requirement and fee structure will provide necessary accountability for companies and staffing providing services to our long-term care communities. We have had a steady increase in calls related to nursing pool agencies working in nursing homes and the challenges related to this shift in delivery. Residents and family members report inconsistency in both care and services due to pool staff not knowing them or their individualized care needs. When there is a question about abuse and neglect, it's difficult to have accountability related to pool staff members or to prevent them from having access to a resident in another facility. Some pool staff work wonderfully with residents and provide excellent care. However, even the best pool staff cannot know a resident's traditional care needs and meet their needs in the same way a traditional staff member would. It naturally takes longer to provide the most effective and appropriate care and services, causing residents to have to wait longer for the care they need, for example, going to the bathroom or getting back to bed. Even prior to COVID, consistent staffing has been one of the primary issues in long-term care. However, since the pandemic, this area of concern has been growing. Nursing homes with high pool staff usage have residents who report not having their needs met in a timely fashion and higher rates of error due to pool staff not being familiar with the resident's care. The registry and maximum rate structure will provide better protections and will help the industry stabilize their staffing ability while ensuring residents have access to the care providers needed. SB 265, an act concerning notice of staff and patient ratios, room telephone access, and asbestos mitigation measures at nursing home facilities. I support this bill as added transparency and access related to notice and staff to patient ratios. In addition to the individuals who are excluded from the count, I would also ask that any staff providing one-to-one support or oversight not be calculated in the same way that the general staff are who are providing care. They're not available to provide services to all residents. Any access or information that provides residents with greater ability to decide where they receive their care and services is supported by this office, and I appreciate the committee's work to expand the access. SB.
Excuse me, I think you're past your 3 minutes.
Oh, sorry.
That's what he was saying earlier. So
Gotcha. I didn't hear that.
Yeah. Am I correct, Cameron?
Oh, sorry.
Right.
Thank you.
No, that's okay. So just wrap it up in 30 seconds.
Okay, I also support Bill 267, an act prohibiting homemaker companion agencies from advertising and making individuals think that they are part of the healthcare system. We can receive complaints related to that, advertising and having a stethoscope or not really allowing individuals to understand the scope of services they can provide. So
Thank you
very much. I'm available for any questions.
Thank you very much. So Maretta, I had a question. We had a public hearing on the registry last week and everyone talked about for the nursing pools, right? And in your testimony, you talk about by, I guess, 5313, that this will allow more protections and stability. Can you go into a little more details regarding that? Because the nursing pool, it's my understanding that they're going to need the nursing pool anyway. So having a registry and them reporting an average, I guess what their average prices are, how is that going to protect the nursing homes, the facilities, as well as cause some, stability, right? Maintain some type of stability.
Sure. So protections, when we talk about providing education and ensuring that the individuals who are providing the care meet the training standards, and that goes to education related to abuse and neglect. We want to make sure that anyone who's coming into the long-term care community understands what those requirements are and the responsiveness. When they're registering, understanding what they're paying the individual going to work for them versus how much the agency is charging the nursing home per hour. Limiting that will limit, I believe, the jumping that we're seeing where so many staff are leaving. And if the staff do leave, making sure that they're receiving the pay directly and that we're not seeing large amounts of money go to just management companies, that the staff who are doing the care are the individuals who see the benefit. And there are benefits to working for the pool, but one of the challenges, they don't have healthcare, they don't have other components that if you're a long-term care resident, making sure that all of that is outlined, people are making educated decisions, but if we can stabilize that staffing pattern, we'd have the ability to consistently provide care in these communities.
So I don't know how much you know about the nursing pools. Are they responsible for making sure that the people they hire are properly certified and licensed?
I believe so. I would suggest asking them, but I believe they have to make sure that they're certified and licensed. But what we see happen is when there is an accusation of abuse or neglect, it doesn't sit with the nursing home where it normally does. Right. So that staff person would be let go. There's an investigation. We hear, well, they're pool staff. We let the agency know. I don't know that that person is now not going to just another nursing home and working with another resident. So there's challenges there.
So do you have any suggestions how we may close that loophole? Because that is a loophole. I mean, the whole purpose of having the oversight, like yourself, right? Agencies is to prevent those type of things from happening and the person being held accountable and not moving from, facility to facility. And so based on just that scenario, I envision someone working with the temp agent, the pool agency, and then the pool agent is just hiring them out somewhere else. Hiring them to go somewhere else. So if you don't have that answer, I would like your thoughts on that. If you, think about that for me, because I think that's a loophole that we need to close as well.
Absolutely. I would like to see what we could do. I think some sort of accountability where if they're working in nursing homes and there's an accusation or investigation, that it's required that also go on their license like it would for a staff member who's working in that long-term care community.
Thank you. I would be interested if you could send me something on that. Thank you. Senator Fazio.
Thank you for your testimony. I wanted to ask about the first bill you testified on, HB 5310 on the 90% ratio on direct care. Now that for requirement for nursing homes, that doesn't include the cost of food or housekeeping or utilities or other costs necessary to run a nursing home, does it?
It would depend on and the scope of direct care and what's related to direct care. But no, there are other costs associated with running the nursing home. And we understand that. And that's why in looking at it, it's just the Medicaid cost. It doesn't include Medicare, other payments, private pay.
Okay, but even for the Medicare, So you are still limiting what they can spend for the Medicare portion to exclude those types of costs
For Medicaid,
for Medicaid.
for Medicaid. Yes, and there's some, so for direct care, it would be the care and services, the hands-on, and I believe that was defined, what direct care is was defined last year, if I'm correct. And what can be counted towards that, yes.
Okay. That's all I got.
Okay, thank you. Senator Fazio, thank you for that, because there was another question I wanted to ask regarding that bill. So Murad, I've been getting emails and questions about the 90%, and we know that 90% is very high. If this bill was to be negotiated, what do you think the lowest threshold should be? Do you have any thoughts on that?
That's hard to say. I think it would be a combination, to Senator Fazio's point. I think it could be a combination of what else is included, but you want to look at and safeguard how that's included. So my apprehension there is related to some of the companies that provide those other services, right? Like food service, dietary, maintenance, are companies that are also owned. So they're outside companies that come in, but may have related parties. And so making sure that the fees associated aren't so high that it shifts greatly and impacts that number, that it would be appropriate.
So you mentioned something that is an outside company that may be related to the owner of the facility?
Correct.
Okay, so, and I did hear that, right? That was part of the impetus for this, is that some of the facilities have interest in companies that provide services for them, like food services, landscaping services. And so it's trying to capture that as well, to make sure that, I wouldn't call it, I'm gonna say double dipping, although it's legal, but it's just making sure that whatever monies are coming through Medicaid, that is directly, it goes directly to the patients. So the recipients of the Medicaid.
I think for me, it relates directly to that transparency. Not that they can't have companies that support the long-term care community, but that it's transparent. When we hear, they're not making any money, their profit margins have greatly been reduced. Yes, on the nursing home, it may look that way. However, we see large fees associated to rent, and there's often an LLC related to the real estate company that has similar ownership. Pharmacies that have similar ownerships, these other costs associated with care and services, where if you totaled it all up, there's a reason why people own these companies. And I think it's just important to have that level of transparency.
Thank you, I appreciate that. Senator Fazio.
So are you concerned that you'd see a diminishment in the overall quality of service provided to the Medicaid patients if you're limiting the spend solely to direct care?
No,
limiting 90% of the spend only to direct care.
That I would see a diminishment in the
overall service that the nursing home is providing to a Medicaid patient.
No, I don't think that we would see a lower quality of care. I think we would see a higher quality of care, because those direct funds would go towards staffing and the support of those individuals, relating in better quality of care and better outcomes. That would be the goal.
Yeah, I get the care part, but if they're in a nursing home and the nursing home can only spend 10% on anything related to, again, housekeeping or food or utilities or whatever else that's necessary to provide the service, is that not a concern that the quality of everything else for the patient will go down?
Well, it's 90% of the Medicaid, not of all of the money that comes into the nursing home.
Yes.
So you would think that would be offset, and that the goal would be that it would all sort of equal out, because then you have the other residents who are also benefiting. Like, let's say someone's on Medicare or private pay, you have the higher ratios that they're benefiting from, but then again, they're also paying into the system and there's access to that fund by the nursing home.
Yeah, but there's still then costs associated with caring for the Medicaid patients. So either those associated costs that aren't related to direct care are going to have to be shifted to the other patients, which we'll see then the prices for the other patients will go up, or they'll have to, those costs, the indirect costs will have to be cut for the Medicaid patients. So that's what I'm wondering, if there's concern about that.
As I said, I would be willing to, or I would even look at what are those indirect costs? What are they truly? What do they look like? And how do they relate per person? And, you know, to Senator Miller's point, if that 90% needed to be adjusted to take that into account reasonably, I think that is something that has come up. Really looking at and holding that level of accountability there. And like I said, going back to transparency, because I think that's the main area of concern when we see this and we hear time and time again that they're not profitable. But when you're paying different bills at home, depending on if you pay yourself things, right? If I mow the lawn and I pay myself, and then I say, well, I didn't have any money at the end of the month in my savings account, I may not have because I paid myself into my checking account, right? But I still got paid. And that doesn't feel like it's in the spirit of being transparent and really explaining what our long-term care system looks like, how that looks moving forward.
Thank you, Senator Fazio. Are there any other questions from the members? Seeing none, Marette, thank you so much for joining us today and offering your thoughts on the bills that you testified on today. And thank you for the work that you do for our older adults in this state. We appreciate you.
Thank you very much. Have a good day.
Next, we have the Honorable, and I can only pronounce your first name, but I'm going to try. Is it Street Kafalis?
Strite is right, and
Okay.
it's Kafalis, your first.
Okay, all right,
stab
great.
at that. You did well. Thank you very much for your attempt. Thank you, Senator Miller, Representative Garibay. I don't see her at the moment. I know she was here a moment ago. Senator Fazio and Representative Wilson, and honorable members of the Aging Committee, and welcome to your new Assembly and Committee members, Representatives McGee and Khan. I am here to testify regarding Senate Bill number 264, an act concerning a qualified deduction from Medicaid applied income for conservator costs. This is a bill that has come up before this committee in the past, and my recollection is that you favorably reported it out of committee last year. It's important to note that the legislation will enable our state to begin receiving federal Medicaid reimbursement for monies expended in providing conservators for indigent conserved persons. It has no impact on the conserved person. Their right to services, care, or conservator attentions are not compromised in any way. It will allow for a more efficient financial management by the conservator for these individuals who are indigent and without family or close friends to serve as fiduciary. And significantly, the federal reimbursement would save, based on current numbers, an estimated $800,000 annually. I did submit written testimony, and I'm just going to highlight a couple of key points. And I know many of you are very familiar with the conservatorship domain and the critical role they play in the state safety net for our elders with dementia or cognitive impairments, individuals with mental health conditions, and individuals with intellectual disability who have assets in excess of $10,000. Right now in Connecticut, more than 22,000 individuals do rely on a conservator to meet their essential needs in the least restrictive means. A large percentage of them and a growing number of them are indigent and rely on the probate courts to locate a conservator to serve as their fiduciary. The mandate to pay for those indigent costs is a very significant percentage of the probate court system budget. The current fiscal year that we just completed, 2021, the expenditure was $5.5 million. And that is only for the conservator. It does not include the expense associated with court-appointed attorneys to represent involuntarily conserved individuals. And that represents about 11% of the probate court system's annual expenses. I want to reiterate the importance of that there is no impact on the conserved person. I know this committee inquired about that last year, and I do think it's important to note that. I think one of the consequences may also be a positive for fiduciaries, because right now the probate courts have to rely on attorneys and non-attorney professionals who are willing to serve as conservator in cases that require intense responsibility. And by easing their efficiency in being compensated by allowing the applied income to be deducted for Medicaid qualification, we may in fact increase the pool of qualified individuals willing to serve to meet the needs of our indigent constituents. Again, the plan the proposal would require a change in the state Medicaid plan, but it would result in a reduction or reimbursement by federal funds for up to 15% of additional spending. I do support Senate Bill number 264. I do want to note that an additional provision in this year's bill proposes a change to the baseline conservator compensation to $125 a month. It's important to note that the probate court system has contract conservators, and they are entitled to a monthly rate of $90. So mirroring that rate may be an appropriate modification to the proposal before this committee. As always, I am willing to meet with Commissioner Gifford, committee members and other stakeholders to resolve what I know are objections to the proposal. And with that, I would leave it with answering any questions you may have for me.
Thank you, Madam. Are there questions from the committee? I have Your Honor, I have a question. You mentioned objections. Can you identify what some of those objections may or may not be?
I do believe Commissioner Gifford's testimony is not only this last year, but this year as well. She highlights some concerns by the Department of Social Services. I would not honestly want to speak on her behalf. I believe she'll be testifying before you later on. But I do just want to reiterate our willingness to work with the commissioner to address the concerns that would benefit the state.
Thank you. Appreciate you coming today. Are there questions from the committee? Seeing none, thank you, Your Honor, for joining us today.
Thank you so much for the opportunity.
Thank you. Next, we have Ted Doolittle. I can pronounce that. Ted Doolittle.
Good afternoon.
Good afternoon, sir. How are you, sir?
I'm very well. Thanks so much.
For
allowing me.
transparency, I want to let the public know that you were listed as number 20 on the list, but when we didn't realize that you worked for an agency. And so that's why a state agency, and that's why you've been ranked to number 4. So I just wanted to let the public know that we weren't skipping people, but this was an oversight. Thank you.
Thanks so much, Senator, and I appreciate your courtesy. And Senator Miller, Representative Garibay, Senator Fazio, Representative Wilson, other honored members of the committee. My name is Ted Doolittle. I'm the state healthcare advocate. And the Office of the Healthcare Advocate is, I call it the best kept secret in state government. We help folks in Connecticut who are fighting with their health coverage. That can include Medicare, any type of health coverage. If you're have a claim denial, something of that nature, we have a staff.
When that decision gets made, it's more about what district has the power
we have a staff of nurses, attorneys, paralegals, and others that can represent you for free. So remember, if you're having trouble with your health coverage, to reach out to OHA, a state agency, for free expert help. I am here today, Madam, to testify in support of SB 260. That's a prescription cost control measure. I support that with amendments, some technical tweaks that I laid out in my testimony. I'm going to refer to this organization as a PDAB, or Prescription Drug Affordability Board, which is what is commonly referred to in health policy circles. So what that is a panel of experts that look at drug prices to make sure that those prices are justified. I want to commend this committee for taking up this matter. We have a medical cost crisis in this country. We spend 2 or even 3 times more than our other wealthy capitalist competitors out there. And it's a ball and chain around our businesses and our families. Businesses profit less because of medical expenses that are extreme in this country, where they're not extreme in other wealthy nations. Family wages are less for the same reason. Sometimes folks in healthcare reform opposing reforms like this one state that we can't afford it. Well, my submit to you, honorable committee, that the status quo is what we can't afford. We have a gold-plated status quo in the United States, and we need to get beyond that. And affordable drugs will give Connecticut an economic competitive advantage. I again want to stress that the prices we pay are globally abnormal. We don't pay the normal prices for these drugs. So we have to take stock and try to make reforms in this area. Healthcare is different from other sectors, other economic sectors. There's no bargaining power in the patient. There's been multiple Nobel Prizes have been awarded for folks who demonstrate that healthcare, in fact, is different from other types of sectors in the economy, and needs to be much more of a public-private partnership situation, more like a utility. And as we know from utilities, Eversource is a capitalist profit-making enterprise, but it is regulated. They have to justify their prices. So too should the pharmaceutical manufacturers have to justify their prices. So we should set up an expert panel to look at the drug prices to make sure that they're justified. This is standard operating procedure in every other capitalist country: Japan, Germany, Taiwan, the list goes on. It's also very akin, this type of price justification process, to how we establish Medicare prices. Thanks so much. I just want to wrap up by saying this is not scary. It's not risky. This is the standard operating procedure in most capitalist countries. This is the way it's really done in the big leagues. And I really commend this committee for taking up SB 260. There are, as I mentioned, some required, what I would regard technical tweaks that are laid out in my testimony. And my office is happy to work with members of the committee or anyone around developing this language further. But thank you for taking up this, and available to answer any questions.
Thank you very much, sir. Are there comments from the members? Representative Wilson.
Thank you, Senator Miller, and thank you, Mr. Doolittle. I wrote down this Office of Healthcare Advocate that I'm embarrassed to say I guess I wasn't aware of, and it was interesting. I had a constituent contact me this week about a health insurance issue that you may be able to answer the question on, and I'll have to get to you for that. So thank you for letting us know your position. So as I read over this bill, and I don't believe we yet have any information from OFA on the cost of implementing this piece of legislation. Could you opine at all? I see a number of things in the bill that say to me there could be some substantial fiscal notes on this. Do you have an opinion on that?
So the technicalities of the fiscal impact are not my expertise, but I will say that generally speaking, these structures are meant to be self-funding. So there would be an assessment or fee pharmaceutical manufacturers or others, such that I can't say that there would be no impact on the general fund because I'm not an expert in it, Representative Wilson. But generally speaking, they gather their own revenue in much the same way that our insurance department gets assessments from the insurance department as opposed to being paid out of the general fund.
And I thank you for that answer. And one other thing that I read here in the bill led me to believe that there could be, I hate to say the word opportunity, there could be incidences where a question of conflict of interest could come into play here when I look at who may appoint and who may be appointed to this board. Do you have any concern about that?
Yes, indeed I do. And I lay that out in a little bit more detail in my written testimony. But I think it's very important for this to be a truly independent body. We're talking about, like, on the federal level, the Federal Reserve might be a model, right? They have a lot to do with regulating the banks, but yet it's a very independent organization. So and the members of the Federal Reserve are subject to financial disclosures and other restrictions on their investments. This because this is such a powerful, financially powerful industry, we will have to make sure that the conflict of interest rules are very well thought out.
And I thank you for that answer. And I have not yet read your testimony, and I will make sure that I have. So if I understood you correctly, you have some suggestions in there.
Yes, and I believe some of the other testimony, including from the National Academy of State Health Policy, NASHP, National Academy of State Health Policy, is really a national leader, as is the Families USA organization. So I think you should have a rich detail in the testimony to go from.
All right, thank you very much for your testimony, and thank you, Madam Chair.
Thank you, Representative Wilson. Thank you for your questions. And Representative Wilson, I have to tell you that the healthcare advocate department or agency is a well-kept secret. And I shouldn't say well-kept secret, but it's a secret in this state, and more people need to know about it, especially our colleagues. I've used it, and they were very helpful in making sure a constituent received a test that they were denied because they had it 5 years before, and were not be able to determine if they had cancer or not. So I want to thank you for your service and for what you do. And you need to advertise more so that more residents of Connecticut know about you, because we run into these problems all the time. So we appreciate the work that you do on behalf of the residents of this state. I saw Senator Fazio. Did you have a question, sir? No? Okay. Well, thank you again.
I'm going to ask just one more question, if I could take the opportunity, Madam Chair. Mr. Doolittle, if you wouldn't mind, please send me your contact information, because I do have a constituent that perhaps needs to speak with you.
Absolutely, I will do that. And anybody within reach of my voice, the website is ct.gov/OHA. That's ct.gov/OHA, but I will contact you personally, Representative Wilson. Please send your constituent our way.
All right, thank you so much.
Thank you. Cameron, you will announce the speakers from this point on, please.
Understood. The next speaker is going to be Regina Stenkus, I believe, followed by Mark McGoldrick.
Good afternoon, Senator Miller, Representative Garabay, ranking members and members of the Aging Committee. I'm here today to give testimony to Bill number 5314, an act deterring fraud and abuse perpetuated against senior citizens, and Bill number 266, an act concerning a registry of persons convicted of financial crimes against the elderly. As I said, my name is Regina Stenkus. I'm a senior, I'm disabled, I'm a veteran, and I'm a victim. Victim is a word that I would never have used to describe myself. I am educated and hold several degrees. I had a career as a business professional, and I never thought this would happen to me, but it did. I trusted the home caregiver healthcare agency. I trusted the caregiver. I trusted the system, and I was wrong and blind in trusting any of them. After my knee surgery, I suffered from post-operative delirium and was at high risk for falling, and therefore needed a caregiver at home. The caregiving vendor claimed that she does background checks. They sent me a known felon who had recent multiple arrests. I was robbed, my identity was stolen, my checks were forged. She rented an apartment. She used my social security number to open up accounts and bought furniture and other items. And I was violated, and sorry about that. I was violated, I was exploited, and I was the victim. My problems and frustrations were only starting. I was frustrated by the complicated system and the lack of direction. You are mostly left alone to figure it out, and I felt abandoned. The trauma or impact of being a victim of senior exploitation is immense. I was traumatized and now suffer from PTSD. I'm afraid of living alone in my own home. I am here today because it is in your power to make sure that what happened to me does not happen to anyone else. While there are laws in Connecticut that are meant to protect older adults from fraud and exploitation, we need to do more to ensure that these cases can be recognized, reported, investigated, and appropriately responded to. That's why I support HB 5314. I believe that our state government should fully support agencies responsible for investigating abuse and neglect, and give them the capacity to respond in a timely manner. Information about these suspected cases should be used in the state survey and certification process, and should be reported to the appropriate state agency and acted on to deter and prevent further fraud and abuse. I also support HB 266. I believe policymakers should require a comprehensive national background check prior to employment of all LTSS workers. Individuals who have been convicted of burglary, larceny, sexual crimes, and crimes involving financial exploitation and other crimes should be prohibited from employment in all LTSS settings. In addition to these measures, creating a registry would help our older adults by giving them access to information about individuals who may pose a risk to their well-being before they hire that person. There are many thousands of other seniors who are victims of elder abuse and exploitation. You may know of somebody or have a family member who's been exploited. I strongly urge you to consider passing these bills. Your elderly constituents are counting on you to protect them. Thank you.
Thank you, madam. And I'm very sorry that you had to go through what you went through. My deepest apology.
Thank you.
Are there members who would like to ask a question or make a comment? No, well, thank you. We appreciate you testifying before us today, because I think it's important for us to see the face behind the issue. So thank you very much for joining us today.
Thank you.
The next person testifying is Mark McGoldrick, followed by Anna Doragazi.
Good afternoon, Senator Miller, Representative Garibay, Senator Fazio, Representative Miller, and other distinguished members of the Aging Committee. My name is Mark McGoldrick. I am the current chairman of the Home Care Association of America, Connecticut chapter, and I am here to testify on 3 of the bills that are on the agenda for today. The first one is Senate Bill 261, which is a state income tax deduction for home health care costs. We think this is a great idea. We're very much in support of it. As you know, a lot of home health care costs are covered by Medicare, but the services that we provide in the homemaker companion agencies are not, and they can be very significant for seniors. And so any relief we can get to the seniors and their families to make the burden on them when they're paying for this out of their life savings would be, very beneficial and helpful. And I know this bill has been raised for at least the last couple of years, and I'm not sure why it hasn't passed. I know that, Connecticut was in a dire financial situation previously. I think that some of the money the state has gotten recently has kind of helped rectify that situation. So maybe this year, something like this would be considered. Senate Bill 262, an act concerning a study of homemaker companion agencies. We support this bill. We think it's a great idea. We would like to participate in the task force. We represent about 100 members of homemaker companion agencies and all of the most significant ones in the state. And we think we could bring a wealth of knowledge and experience to the task force. So we would welcome the formation of the task force. And the last bill I want to testify on is Senate Bill 267, an act prohibiting homemaker companion agencies from advertising provisions of health and medical services and expanding penalties for violation of conditions for authorized operation. So we oppose this bill, and let me explain to you why. We don't have any issue with the fact that homemaker companion agencies should not be discussing or giving the impression to the consumer that they provide any type of medical care. That's not the issue that we have with this bill. And we've been going back and forth with the Department of Consumer Protection for quite some time on this matter. The problem resides with the care for those seniors that have memory challenges, right, that have dementia. There is no medical care for a dementia client. Dementia clients, the care that a dementia client gets is 99% provided by homemaker companion agencies. And it's behavioral in nature, right? We help them with all the activities of daily living, and our caregivers have a lot of experience and are trained in how to deal with people who have memory care issues. There are, special ways to communicate with these people and how you approach them and how you address them. Those are skills that are not medical in nature, but if a bill like this is to pass, it's really going to harm the consumer because home health agencies don't provide these services. Skilled nursing facilities don't provide these services. So, we're concerned that there won't be any information available to the consumer on where to go to get help for their parent or their loved one with dementia. Thank you.
Thank you, sir. Are there questions from the committee? So I have a question. First, I started with a comment. This bill, the issue was brought to my attention, and I actually saw the advertisement, and I have the file, where a homemaker agency advertised that they provide health services. And that's what the impetus of this bill is. I understand what you're saying, but we don't want the public to be misled that agencies provide home health services, healthcare services. And that's the problem with this bill. I know my father had a home health aide, homemaker, and I know that I didn't know what they could or could not do, right? What they were allowed to do. And so this bill is about transparency, and it is important that the client know, or their family know exactly what you can provide, but not to provide that you, or advertise that you provide those services, and then the family thinking that you are performing those services when you actually can't, the agency actually cannot perform those services, but have led the family to believe that they have performed those services. And yes, we know that there's a contract, but who really reads the fine line of the contract, right? So that's what this is all about, Mark. It's about not trying to tie your hands, but it's about transparency and the owners being honest to the people that use their services. You have any comments?
Yeah, I have no issues with anything you've said, but the problem with this broad of a bill is, again, DCP will tell us, and they have, you cannot advertise that you have caregivers who have experience providing non-medical home care services to seniors that they have experience with dementia clients. Okay. And if I'm a family looking for dementia care for my loved one, and the homemaker companion agencies cannot advertise that they provide those services, I'm not going to know where to go. Google's not going to be able to put me anywhere. So I'm going to be in this online death loop with no idea how to care for my parents. So we're only talking about, again, homemaker companion services for people with memory care issues. That's the single item that we're talking about. We totally agree that it's wrong for any homemaker companion agency to represent that they provide nursing services. That stuff's very clear to most, members in my association. And, there are bad actors out there, so we understand that. But we're very concerned about this black hole that could exist for people looking for memory care. And I will tell you that for homemaker companion agencies in the state of Connecticut, at least a third of their client base is memory care issues. So it's the single biggest illness that we work with.
All right, well, thank you. And I appreciate your comments and bringing that to our attention. Are there any questions from the members of the committee? No, thank you. And again, thank you. And I appreciate your association willingness to be a part of the task force. We appreciate that.
Thank you, Senator.
The next person testifying will be Anna Doragazi, followed by Jesse Martin.
Good afternoon, Senator Miller, Representative Garibay, ranking members, members of the Aging Committee. Thank you for the opportunity to speak with you today. My name is Anna Doragazi, and I'm one of the policy directors at AARP Connecticut. We've submitted testimony regarding 6 bills on your agenda today, but I'm going to focus my comments right now on just 2 of them, HB 5310 and SB 260. House Bill 5310 would require nursing homes to spend at least 90% of their Medicaid revenue on direct care. This idea is similar to the medical loss ratios that require insurance companies to spend a high percentage of their premiums on medical claims and quality improvements. The goal of direct care payment ratios, which have been set in Massachusetts, New Jersey, and New York, is to create more transparency and make sure that nursing home revenue, 3/4 of which comes from Medicaid in Connecticut, is spent in ways that most benefit residents. Connecticut has some excellent nursing homes, but like most industries, there's a big gap between your high performers and your low performers. Facilities that invest more in their staff and residents have better outcomes. And there's really frightening data out there that shows what happens when nursing homes don't make those investments, but instead treat the facility like an investment opportunity. We really like the portion of the bill that would require the creation of plain language summaries of annual cost reports. Having uniform summaries of these reports would make it a lot easier to understand how nursing homes use their revenue and give us an opportunity to drill down into what funding practices in particular might lead to better outcomes. That said, in terms of uniformity, it might make more sense for the Department of Social Services rather than the individual nursing homes to produce those summaries. So it's the same person across the board creating them. Switching gears, we have some concerns about the details of Senate Bill 260, but we very, very strongly support its intent to create a prescription drug affordability board. I think we're all very familiar with how high prescription drug prices impact older adults and people of all ages, but one of our volunteers, Novlet from West Hartford, put the magnitude of the problem very succinctly in the written testimony that she submitted today. In her testimony, she describes the experience of going to CVS to pick up a prescription for her congestive heart failure, which even with her insurance cost $416 for a 1-month supply. In her words, I did not have the money to pay for my medication, so I went home that day and told myself that maybe it was my time to die. Her story has always stuck with me, and it is unacceptable. Americans pay some of the highest prescription drug prices in the world, and a growing number of states are creating drug affordability boards to lower the amount that people pay for their medication. A drug affordability board is an independent body established by the state that evaluates drug prices and sets limits on how much certain payers, including state agencies and private insurers, will pay for high-cost prescription medications. Affordability boards are based on the precedent of healthcare rate setting and state regulation of public utilities, where you have a group of appointed individuals reviewing relevant information and then setting limits on what buyers may pay for certain goods and services.
Ms. Doragazi, your time is almost up.
All right, there's a lot more we could say about these two bills. I know I'm at the end, so I just wanted to say thank you. I know these are two very difficult but very important issues, and I appreciate that you've given us the opportunity to speak about these bills today.
Questions from the committee? Representative Hughes.
Oh, thank you, Madam Chair, and thank you so much, Anna, for your testimony. I wanted to just make sure that we had your, in your written testimony, any language suggestions submitted about the transparency when you talked about the high performing facilities like mine versus the others in terms of that are not as transparent in where they invest, where their costs are, and where the, you know, where the money is invested in terms of direct care. If you had suggestions around that, it was my one question, and in terms of clarifying the language in our bill, and secondly, do you see any difference between the for-profit model and the nonprofit model in terms of investments in personnel?
Yeah, so I think you know, to maybe answer your second question with the first question. I think I'd love to be able to drill down and do that analysis of, you know, do we see different investment trends between for-profit and nonprofit? Do we see different investment trends between facilities with high ratings and low ratings? I think for me, that is part of why the transparency piece feels really exciting, because it takes data that the state already has in the form of is cost reports, which I'm sure people are pouring, you know, lots of hours into making these. They're very, very detailed. But, you know, having a high level analysis that would let you sort of look across the board and say, you know, hey, we know that these are sort of our 10 top performing facilities for staff retention or for, you know, whatever outcome. And then say, you know, can we see any similarities around how those facilities are investing their money? Can we see, if we look at lower performing facilities, does that appear very different? So I think it would just give us, you know, more information that would allow us to, you know, moving forward, try to prioritize which of these factors in terms of revenue and investment do make a difference. And I actually think I forgot your first question in trying to answer the second one.
Well, to that end that you just talked about, what I'm wondering is if, because we passed a bill last year and you were involved in testifying about the direct care ratio, moving from 2.1 hours to 4 hours. And if we could see in this bill how those investments are made, could we, again, a lot of these are private you know, industries that we don't have a lot of direct we don't have direct authority over, quite frankly. What we do have authority over is the payment of Medicaid dollars. That's it, right? And in MAPOC, we have some oversight about Medicare dollars too, but we can't really tell private industry how to invest. However, with that data, we could see amazing outcomes, right? And we can, and that is reflected in the potentially in the ratings, which, you know, consumers are going to use to choose facilities for their loved ones. And so it's not about really regulating it as much as giving really important, helpful data to the consumer to make choices about.
Yeah, and you know, perhaps it helps us understand what are best practices to achieve you know, things that we've already set as standards, right? So the new standard around you know, 3 hours of care per resident per day. For facilities that are hitting that target, are they investing their, you know, or is their money being allocated in different ways than facilities that are struggling to hit that target? So I think the legislature has done a lot around nursing homes in the last couple of years. But I think this piece around transparency and better understanding how the money works, I think just reinforces a lot of the work that's already been done.
Great. And you said you did submit written testimony, right? Around all the bills that you are.
I did, yeah. And if
take a look at that, I'm sorry, I haven't looked at it
no,
carefully.
that's okay. But if there's anything that I didn't touch on in the written testimony, where it'd be helpful to have some additional information, I'd be happy to provide whatever you need.
Thank you. This is really helpful. Thank you, Madam Chair.
So with that being said, what were the other bills you were testifying on today?
So the ones that I did not speak to were 5314, an act deterring fraud and abuse, which our excellent volunteer Reggie spoke to already. An act concerning a study of homemaker companion agency issues, that was SB 262. We also
and what was your position on that?
We support that. For 262, our position is that the state's done a great job in recent years of rebalancing the number of folks who are served in home and community settings as opposed to institutional settings like nursing homes or residential care homes. But in the process of that, I think it would be good to take a deeper look at how can we better understand and support home care agencies. We do from time to time, there's some great home care providers out there, people who are doing a good job. I tend to not get calls about the folks that are doing well, but we do hear from members who have had very negative experiences and have a lot of questions about, how is the industry regulated? How could it be improved? And I think, now as we're seeing more people than ever receiving care in those home and community-based settings, I think this is a great opportunity to have a conversation around, what's working, what additional support might be needed, and where are people having positive and negative experiences within this service.
Were there others, or that's it?
And also SB 263, an act concerning refunds for the balance of the gift card.
Okay, I have a question regarding that. Are there questions from the committee? No, so I have a question regarding that, but before I get to that, you talked about Massachusetts, New Jersey, New York having similar legislation around direct care, the spending of direct care for Medicaid recipients or patients. So do you have an idea what their percentages are?
Yeah, so each of the three states have taken a little bit of a different approach. So Massachusetts requires 75% of all revenue, so Medicaid, Medicare, private pay, to go toward direct care. And they did that, I think, more through like an executive, regulatory process.
Mm-hmm.
New Jersey's law was legislation originally, and as written in the legislation, it was 90% of revenue being spent on patient care. They're developing the regulations for that now, and they're going back and forth in conversation about should that be applied just to Medicaid funding only or all revenue. And then New York, which I think embedded this proposal in their budget, had a 70% of total revenue toward direct care.
So our legislation says Medicaid only, but New Jersey, I guess Massachusetts and New York are looking at all revenue. So that includes the Medicare and any other funding that they may get. Is that correct?
That is correct. Yeah, New Jersey started looking at all revenue in the regs making process. I think what they had originally proposed in regulation was a switch to just Medicaid, but it had started out as all revenue.
Okay. Are there any other questions before I ask my next question? Senator Kelly?
Good afternoon. Thank you very much. Just one question while we're talking about these three states, and I'm not so sure you'll have the answer to this, but I think it's important to the conversation, is what is the actual Medicaid reimbursement rates from the federal government? As I understand it, Connecticut and Connecticut Medicaid rates pay a portion, so it's a discounted rate, and we're somewhere in the neighborhood of about 60 to 65%. Are New York, New Jersey, and Massachusetts at that same rate, or do they have a higher rate? And I think most states do, quite frankly, but I think that's an important part of this process. Because I think when we look at this, I understand the model that we're looking at a medical loss ratio like they do with insurance companies. But here, the insurance company is occupied by the state Medicaid agency, the Department of Social Services, who provides these benefits to a vendor, i.e. a skilled nursing facility, for the benefit of the patients. And that medical loss ratio in the insurance area is looking at the carrier, not the medical providers, to deliver the 90% care, which is a substantial difference. If there's a market failure, I think the market failure is in the state government in not providing adequate Medicaid reimbursement rates to the nursing homes. And my concern here is that a cap of this type is actually going to reduce access, because these providers will no longer be able to exist, which ultimately will hurt individuals who are on that chronic care continuum. So it may actually have the opposite result of what I think we're trying to accomplish here, which is to make sure that the patients get the care that they need. As I've always said, human services demands human services, but I don't think it's done through caps. I think it's done through carrots and actually funding the Medicaid reimbursement rate at the proper level. Thank you very much.
Yeah, and thank you for raising that point. I don't happen to know that, in my notes or off the top of my head, but I will circle back to you and your staff I'll get my hands on those and let you know.
Thank you, Senator. Senator Fazio, did you have a question, sir?
No, I'm okay.
All right, thank you. So the other bill, the 263, you were going to testify on that. I have a question for you, and it's not in the bill itself. Section D of the bill states that in order for a person to receive that cash refund, that they have to present a receipt. Do you have any thoughts on that, about having to present a receipt in order to get your cash refund?
Yeah, I mean, I don't know that AARP has formal policy on that, but I would think that if you don't have to present a receipt to get a $10 benefit from a gift card, I don't know why you would need to present a receipt to get, the smaller cash value for that.
I'm sorry. Thank you. Are there any questions from the committee? Anna, thank you very much. Anna, thank you. I appreciate you being here today, and your organization for what you do for the aging population in our state. And I miss those red t-shirts. So
well, one of these days, we got them ready to go. We'll be back.
No, but I have to let the public know that your organization are very strong and lobbying and advocating for issues that are important to the aging population in our state, the older adults. So thank you very, very much. We appreciate you.
Yeah, thank you all very much. Have a great day.
You too.
The next person testifying will be Jesse Martin, followed by Carmine Perry.
Good afternoon. Senator Miller, Representative Garibay, and the rest of the Aging Committee. My name is Jesse Martin. I'm a Vice President with 1199. I have the distinct pleasure of representing 7,000 nursing home workers and hospital workers across the state of Connecticut. 1 out of every 3 nursing home workers in the state is represented by 1199. I'm speaking in favor of 2 bills. House Bill 5313 and House Bill 5310. Nursing home staffing has been a tremendous struggle even before the pandemic, and during this pandemic has caused even more suffering in the nursing home population, both with the staff that we represent, but also with the residents that need quality care at a timely way. We support HB 5313. We believe that these staffing agencies do need to be regulated. They are taking money, state dollars, Medicaid dollars from these nursing homes and charging significant additional fees towards nursing home operators, in addition to the wages that the agency staff are taking. We also support the use and creation of a registry of staffing agencies to make sure that there are properly licensed, and also that the operators themselves, we know who they are. There are several nursing home operators in the state of Connecticut that have their own staffing agencies. And that leads me into Bill 5310. One of my roles in the union is negotiating contracts on behalf of our members in nursing homes. I'll be quite frank. We believe that that Medicaid dollars are not being spent on direct care. That somewhere around 51% of Medicaid dollars are being spent currently on direct care. Only 51%. I'll give a few examples. St. Mary's Home is a nonprofit nursing home in West Hartford. They are a member of Leading Age. By the way, Leading Age and the Nursing Home Association, the membership fees that each nursing home pays, which sometimes range between $10,000 to $50,000 a year, comes from Medicaid. And that's money that should be spent on the residents and the care of the residents in the nursing homes. But St. Mary's Home in West Hartford has taken $2.2 million worth of Medicaid dollars away from direct care to pay for the CFO, the CEO, and their administrative assistants' salaries. 3 people in the nursing home get paid $2.2 million. That is really atrocious. Another nursing home operator represented by the Nursing Home Association is National Healthcare. They've testified on some of the bills that this committee has had over the last few weeks.
Mr. Martin, your time is almost up.
Thank you. Very quickly. The owner of National Healthcare, Marvin J. Ostreicher, pays himself a salary from each one of his 38 nursing homes across the state in Connecticut, Massachusetts, New York, and New Jersey. He has siphoned off hundreds of millions of dollars annually in Medicaid dollars through his related entities. He pays himself rent on property that he owns, on companies that he owns that does services, and also their own staffing agencies. These are all Medicaid dollars that need to be spent at the bedside, feeding, clothing, and giving dignity to our residents, not for corporate profits. Thank you.
Thank you. Questions from members. Representative Garibay.
Hi, how are you? Thank you for your testimony. You mentioned that there are significant fees by the staffing agency. Can you give us an idea of what those fees look like?
Sure. I was talking with a nursing home operator where we represent CNAs, LPNs, and RNs, and they've struggled to find permanent staff. They contracted with an agency that's based out of the state of Connecticut and New Jersey for an LPN to work the 3 to 11 shift 7 days a week. They were not just charged the $50 an hour for the wages of that nurse. They were charged $150 total for that nurse to provide those services. So the nursing home was paying competitive wages to the agency staff, and they should get that money. They work for it. But the agency was taking 2/3 of the total dollars for their own fees or profit. And that is the concern that we have. Workers should make competitive wages and benefits. That's what we do every day at 1199, advocating for our members. But it's the additional fees, either per hour or on a contracted basis, that these agencies keep increasing. And there's no cap, there's no limit, and there's no public disclosure. And so the nursing home operators themselves are also competing against each other, which is all of our money. It's all Medicaid money. And so it's quite problematic that, one, we don't know where those dollars are going. Like in this case, that additional $100 an hour, right? $800 7 days a week in this case is going out of the state of Connecticut. That's not fair.
I agree. Is it true, what we've heard, that when you say they compete, they actually go out to bid? Saying,
Yes.
We have 2 employees, there's a need for 5, what's your best offer type thing? Is that really happening out there?
Yeah, there's actually one agency I know quite well. They've targeted trying to recruit union members, which is interesting. They actually use an app, and let's say CNA in this case, I was talking to one of our CNA members. She gets on her phone on the app a given day. She's listed all these open shifts at various, let's say 20 or 30 different nursing homes. And each shift is a different dollar figure per hour that she can earn. And she gets to pick which one she wants to go to. And, oddly enough, nursing home workers have been so underpaid for so long. I don't fault our members, and I don't fault nursing home workers trying to earn what their work is really valuable for, right? They should be making these high wages because their work is quality and good. But now, in this case, this CNA, she gets to pick wherever she wants. She was working at another union facility for 4 times the hourly wage. And then the employers are also bidding against each other because she's not selecting to go work at that other nursing home that is only offering an agency staff, let's say $30 an hour. She's going to go the one that's offering $40. And it's a race to the top, all with our public dollars.
Right. Thank you for that. And just one last question. You talked about nursing homes owning the auxiliary businesses, like the landscaping, the food providers, etc. How common is that?
It exists in almost every nursing home operation. It's completely legal. And in 2014, the state legislature passed the Nursing Home Transparency Act, which was landmark legislation in the country to require nursing homes to show us when they're paying these related entities $50,000 or more per year. Well, what we have seen over the last, almost decade of that financial reporting is the diversification of these services. So you have a nursing home operator like National Healthcare. All of these entities are owned by Marvin Ostreicher or one other individual. They own 37 different companies, one company for each land, one company for each nursing home, one company to do all the therapy and other financial services. Plus, he collects his own salary. He owns all of these other entities, and he pays himself rent from the Medicaid money. And so, that's really disturbing when you look at, and when I get phone calls from our members saying that they have one nurse's aide to 30 residents who they cannot get to the bathroom in a dignified way because of how much they're working. Someone like this at National Healthcare, really, where should the money go? Is it paying rent for him to rent? He owns the building. He's paying himself rent with a little profit margin on it. Mm-hmm. I think that money should go to making sure there's enough nurses' aides so that people can go to the toilet.
Right. So, I'm not against an owner making a profit, right? When the employees are taken care of and the elderly is taken care of and everybody's, it's great to make a profit. You're the business owner, but I agree, we have to take care of our employees and our elderly. Thank you for answering my questions.
Thank you, Representative.
Representative Hughes.
Oh, thank you, Madam Chair, and thank you, Jesse, for this sort of in-depth dive as to what this legislation is attempting to address. Just a few points of clarification. You talked about that bidding war climate that's going on out there and the apps, and how does this affect contract negotiations for permanent staff in your experience?
I've been negotiating contracts on behalf of our nursing home members for 10 years. The nursing homes are taking in Medicaid dollars to care for the residents. And then a huge portion of those Medicaid dollars are being taken away from the permanent staff. And we're being told, well, the agency's taken all of our money. I can't give a raise. I can't put more staff on the floor. I can't give them more sick days. And that's really problematic because what they're essentially doing, the way that these agencies are acting with these additional fees, is that they're taking money, our state dollars that are meant for state residents, the care of vulnerable Connecticut residents, and they're leaving to go to corporate profits. And that's problematic from these staffing agencies. And the nursing home has the documents they can show us, right? But their bank account is now drained. And they can't commit to a contract with our membership in some cases, or have problems committing to long-term contracts to provide stability to the residents at the nursing home because of this flow of money. It's kind of endless empty bucket of money.
And what are you hearing about the amounts that they are paying these agency fees? What are the nursing homes paying? What are you hearing?
Sometimes nursing homes are paying fees to the agency of 2 to 3 times what they're paying for the agency staff's hourly rate.
Got it.
Let's say I'm making $30 an hour as a nurse's aide.
Mm-hmm.
Well, the staffing agency is collecting $60 on top of my $30 from the nursing home. So the nursing home's paying $90 an hour for the staff. That's just unsustainable.
Somebody's sorry about that. So you talked about in your opening remarks that this really is a staff resident ecosystem. You can't separate the quality of the ecosystem that this care industry operates in. I mean, you can, and that's what's happening, but it's really who does it harm? It harms the residents. It harms the residents. And I see this firsthand in the nursing home I work on with the staff shortages. And this is a facility that works really hard to affirm, to pay, to support its direct care staff and increase that direct care staff. So when we talk about, okay, so we need to have some oversight, we need to have some transparency, and we need some accountability from this industry that's largely unregulated. If we base the rate cap off a maximum percentage that the agencies can retain, how would that work?
Well, I think that, one, you're not capping the worker, right? Which is important. You're capping what the agency takes home in their profits and in their mechanisms. And you would do that as a percentage, right? Let's say that they can only charge 50% per hourly wage. So if the nurse's aide is making $30 an hour, instead of collecting an additional $60 an hour for agency fees, that's cut down to $15 an hour, or whatever. Any sort of way to be able to put some constraints on the ever increasing demands by the agencies to increase their fees is helpful in this case. And you're right, the value of nursing home care comes in the regular consistency of staff. You know, we're all quirky in our own ways. We all like to put our socks on in a certain way, right? We all get dressed or go to the bathroom in our own unique ways. And it's the regular staff that are there 5 days a week, in some cases, 7 days a week, that know my quirks, that know our residents' quirks in these nursing homes. And that quality does transition to better medical outcomes. Because, you know, let's say today I wake up and I'm a little different. My wife goes, Jesse, why are you a little different today? Well, she's seen me every morning, right? Same with the staff. Those little changes in condition. The number one thing that our CNA members do is not only assist residents in their activities of daily living, the ADLs, but they also are the ones to report changes in condition. Those little changes. He looks a little depressed today. She's not getting up. She doesn't want to go to the dining room to say hello to her friends. Those little changes can be the beginning signs of major medical problems, mental health issues, and it's the permanent staff in these nursing homes that identify that quicker because they know the people they're caring for. You just can't put a dollar figure on that kind of quality.
Exactly. And it's unconscionable that we're exploiting that to profit off of that at the cost of the continuity for our residents. So if we look at this ecosystem, do you and you represent folks or your
Excuse me, Representative Hughes.
Yes.
I love the dialogue between the two of you, but I had asked the members to hold your questions to 2.
Perfect.
Then we will come back to you. So I'm sorry to interrupt, but I have Representative Wilson, who's been waiting very patiently.
I can't see you, Wilson. David, sorry about
No,
that.
that's okay. Thank you very much. Representative Wilson.
Thank you, Madam Chair. And I'm a patient guy. You know, I guess we learn from the dialogue. So Jesse, I really appreciate the information that you're bringing forward. I certainly don't know anything about the management of long-term care facilities, and I'm trying to understand better the difference between the contracted staff. So in my world, I would call that the W-2 staff. And then these other folks that are being subcontracted in, are they 1099 independent contractors or are they employees of these agencies?
Most of them are 1099s. Some agencies do consider them employees, but that is much more rare.
So in thinking the process through and trying to understand from a business operational standpoint, then the contracted employees, the W-2 employees, have something in their package in addition to their hourly compensation, i.e. benefits, 401ks, medical insurance. Where am I correct then in these subcontracting agencies, they do not offer benefits like medical and 401ks?
Yeah, and I think the other point to include in that, Representative, is Connecticut paid sick days, right? If you're a 1099 subcontracted employee and you are not required, the agency is not required to give you any sick days or any time off. These are medical professionals. If I'm working an employee of a nursing home and I'm, as you put it, a W-2 employee, if I'm working and regularly, I get Connecticut paid sick days. Under the law, in our contracts, which are more generous in the facilities we represent, they get somewhere between 10 and 12 sick days a year. But yeah, it ranges, but the vast majority of the people working in these staffing agencies are 1099. And in that, they get around some of the fundamental requirements as an employer, but also some of the fundamental pieces of our healthcare system. Healthcare workers should be provided sick days. So, and in particular, they should be provided sick days so that they don't have to come into these facilities with COVID-19 or something even more problematic.
So again, I'm trying to do this from an operational understanding. I'm trying to figure out then if these subcontracting agencies are paying 3 times that base amount. So in other words, if I understand correctly, it's $30 to the employee and it's $90 to the agency. Why do the facilities hire these people? In other words, are the facility costs less than the subcontracted costs? Why are they hiring these people?
There's 2 reasons. And this is a great question, Representative. One, they're required under law to have enough staff to care for the residents. So if they can't find employees to work in these facilities, they need the staff anyway. So regulatory wise, they're compelled to find outside subcontractors. 2, the second reason is some of nursing home operators in the state of Connecticut have their own agencies. So for example, National Healthcare, Athena, and other large nursing home chains in the state of Connecticut operate closely related or completely related entities that are these staffing agencies. Apple Rehab has their own agency. And so they pay these fees to themselves. This goes back to the Medicaid cap issue in HB 5310, but they pay themselves these additional fees. And that creates a lot of synergy when it comes to cash flow that they can put into their businesses. Again, siphoning money, state and federal dollars away from the bedside.
All right, I appreciate your explanation. That helps clarify it in my mind. Thank you so much. Thank you, Madam Chair.
Thank you, Rep. Wilson. Representative Vargas.
Thank you, Madam Chair. I go to a barber shop in the town of Berlin on the Berlin Turnpike. And when I get my hair cut there, I notice across the street on the other side of the road, there's a CNA agency that places healthcare workers on. They call themselves the Euro CNAs. And it disturbs me because it makes me wonder, what are they saying to people? We're guaranteeing you a white CNA. Are you aware of this agency? Can you tell us something about it, Jesse?
Unfortunately, Representative, I'm not aware of that agency, but I'll definitely take a look at it after this call.
Yeah, they're located on the Berlin Turnpike, right across from MC Barbers, and they say we're the Euro CNA agency. And it's very disturbing because from what you're telling me, if they're making $90 an hour, I'll tell you, most of the people that work where my mother, who has Alzheimer's, Avery Heights, which is a union facility, don't make anywhere near that money. And they're mostly Jamaican immigrant women who are working these tough jobs at Avery Heights. And it disturbs me that they would have an agency peddling to the community saying that their employees are Euro employees. To me, it sounds like some kind of racist come on.
Look, Representative.
But anyway, thank you, Madam Chair.
Yes, thank you, Rep. Vargas.
Yep, go ahead, Jesse.
Yeah, did you have a comment, Jesse?
Yeah, I just wanted to say that, Representative, oddly enough, Avery Heights today is doing an informational picket at 2:30 because we are in contract negotiations where the employer has refused to meet our standards for the permanent staff to make competitive wages and benefits there. And this is a classic example of they have not used agency at Avery Heights, but there are definitely staffing issues. And back to Bill 5310, Avery Heights is allowed, along with other nursing homes in the state, to take money from Medicaid to pay for their fees to join Leading Age and the Nursing Home Association. And those aren't cheap. Those are sometimes between $10,000 to $50,000 a year. That's one CNA's salary. You know, that's one less bedside person. So just as an example, thank you, Representative.
Well, thank you, and thank you, Madam Chair.
Thank you both. Representative Hughes.
Yeah, for the second time, thank you so much, Madam Chair. And just real quick, Jesse, as you again address HB 5310, the Medicaid cap, I want to, as part of 1199 and SEIU, the organization represents the whole Northeast, and we are trying to address the shortage, the healthcare workforce shortage of the whole Northeast. So I'm wondering how we can use these pieces of legislation smartly across the region so that we don't engage in bidding wars with our border states or the workforce that can, that can use an app almost like Uber to see where they can go close by if they're, down in Lower Fairfield County or up on the Massachusetts border. So how
That's
could
right.
we more in line, I suppose, with our neighboring both caps and and HB 5310 too. Yeah.
Yeah, look, both HB 5313 and HB 5310 mirror exactly what all of our regional partners have been doing. Connecticut has based its COVID-19 response for the last 2 years based on a regional approach.
Mm-hmm.
Okay. And we should look at the nursing home industry in the same way. There are 3 kinds of nursing home operators in the country. Mom and pop facilities that are owned and operated by one facility, by one group of people.
Right.
Nursing home regional chains.
Right.
Apple exists in all of these states. National, Athena, iCare, Genesis, all are regional or national chains, which are the other 2 forms. And so they operate both in New England and the Northeast or across the country. And we need to have a regional approach because, as we've seen with COVID-19 and as we've seen with other changes in long-term care, profit and profit-driven decisions continue to creep into the way that really affect the bedside care of people, whether it's in their homes from home-based agencies, or whether it's in nursing homes for more medically necessary care. And it will help all Connecticut residents to be able to have a regional approach to deal with these companies that are also regional. In the regional chains that I listed, that's over, if you combine Athena, Apple, National, and iCare, you're talking over 60 nursing homes in the state of Connecticut in 4 companies that all operate in that sub-regional chain of Massachusetts, Connecticut, New York, and New Jersey.
That's incredibly important as we finalize our legislative approach, is to align it with regional partners in terms of setting minimum standards of care and also addressing a regional workforce shortage. And I just wonder, as Senator Kelly mentioned, our Medicaid rates aren't on par, our reimbursement rates with our regional partners, yet all of those that you named, they all have 70% of their residents in long-term care on Medicaid, right?
Well, exactly, Representative. And some of the nursing homes in the companies that I just listed are spending only 51% of Medicaid dollars at the bedside. So, though there are funding issues in this industry, what we have found is that when the legislature earmarks specific funding to go to specific programs within the nursing home industry, it works, such as funding directed for wages and benefits of workers, funding directed for capital improvements of the facility, okay? And funding directed to make better the ratio of social workers in nursing homes, which was a huge victory for for Connecticut nursing homes to go from one social worker to 100 residents, to splitting to doubling the number of social workers throughout the state. That solves a lot of these issues. But here, there are companies that are operating with only 51% of their Medicaid dollars going to the bedside. Where are the other 49% going? They're going to corporate fees. They're going to, like at National, they're going to one person who owns almost, I think, close to 45 different companies in 38 nursing homes, who's a multimillionaire, and he's collecting a direct paycheck when they don't have enough nurses aides on the floor. So, that's where the Medicaid dollars are going. The state can be much better at regulating this if we have specific ways that we want our dollars to go. If this cap would really focus on keeping Connecticut Medicaid dollars in Connecticut. The CNA, if they work at the nursing home, they don't live in Massachusetts, they live in Hartford, they live in Meriden. I'm just down the street from Arden House in Hamden. 90% of our members live in New Haven and Hamden that work at Arden House.
Yeah.
Right? So that cap on Medicaid dollars is actually going to put more money into our economy, because it's going to take a lot less money to these corporate profits out of state.
Good point. Thank you. Thank you so much for your testimony. This is really helpful.
Thank you both. Senator Miller, did you have a question?
Yes, I did. I put my hand down. I had a question, Jesse, on 5313. I've heard stories that there's price gouging from these pooling agencies. For instance, you have an agency that contracts with a pooling service, and the person may call out because they put that particular worker out to bid, where they could get more money for that person, or not even say the contract is that there may be 3 agencies that are looking for someone in that day, and that these agencies are going to the highest bidder. Have you heard any stories like that?
Every single day of my life, since especially the last, I would say 8 to 9 months, daily, I receive notice from members in nursing homes around the state, from Danbury to the Rhode Island border, where they are short-staffed because the agency was not able to produce the staff to care for the residents, because the agency decided to send their staff to a higher-paying nursing home. And it's just atrocious. That means that in some cases, the residents aren't able to go to the bathroom, aren't able to be fed on time, and it's really, really problematic.
Thank you. And I was told that you answered that question. I apologize. I had to go and vote in another committee meeting. So thank you very much for the work that you do. And not only the work that you do, but the people that you represent, the work that they do. They held it down during COVID. Some of them even contracted COVID themselves. So I want to personally thank them and let them know that we see them, we hear them, and we appreciate them. Thank you.
Thank you, Senator.
Thank you, Senator Miller, and thank you, Jesse, for coming today.
Thank you very much.
Up next will be Carmine Perry, followed by Matt Barrett.
Hello, Mr. Perry.
Good afternoon, Representative Garibay and Senator Miller and members of the Aging Committee. Thank you for your time this afternoon. I'm the Vice Chair of the Elder Law Section for the CBA. You speak today in support of House Bill 5314. Most of us get used to our patterns, our habits, our routines. But what if you encounter something new, something foreign, something pretty complicated? Such is the case for seniors and their families, certainly with respect to admission into a nursing facility. And then navigating the paper chase and the complexity of a Medicaid application. It can be onerous, it can be overwhelming, among many other words. So when confronted with a challenge or a new or unique experience, some folks turn to others for assistance, others who have purportedly done it before. And it is this crossroad, the crossroad between a problem and a possible solution, where so much can and so much does happen with respect to a lot of things, but certainly with respect to the Medicaid application process, which I believe is why the task force for protecting seniors from fraud, which was enacted by Public Act 21-84, was put in place. As this group, I'm sure, is aware, that the task force met a number of times to discuss various issues with respect to exploitation and senior fraud. And one of the issues with respect to this bill is disclosures from persons assisting elderly folks with the Medicaid application process. So focusing on those applications, there are various places to go with respect to tips and tricks and how to complete an application. There are non-attorney service providers, there are attorney service providers, elder law attorneys available. But this is about an informed choice. And that's where that crossroads really becomes the biggest issue. Are you able to make an informed choice if you don't know what you don't know with respect to the following? Is there a relationship between a nursing facility and a non-attorney Medicaid advisor? Are there company referral forms from a nursing facility to a non-attorney Medicaid advisor? Are there links for residents in a facility where they can contact a company representative for a non-attorney Medicaid provider? Instead of that person contacting whomever he or she chooses, someone from a non-attorney Medicaid planning or purported planning service will call these folks. So there's really not much by way of disclosures with respect to that.
Mr. Perry, your time is almost up.
Thank you, sir. And that's one of the many reasons why the elder law section supports House Bill 5314. And I respectfully request you consider remarks submitted by Attorney Lang, Attorney Rubin, and some others.
Thank you so much. Senator Kelly, you have a question, sir.
Yes, thank you very much. And thank you, Attorney Perry, for your testimony. Can you give us some examples of how this may occur?
Sure. I have heard and been made aware of examples with respect to a Medicaid application being promoted by a facility. In other words, a facility saying, you should fill out a Medicaid application. And we are aware or we know of a company or companies that could assist you. There aren't disclosures with respect to what, if any, relationship there is between that nursing facility and these companies that provide those services. So there are questions with respect to what the representations and the statements are made by these services and these planning companies, and whether their advice is with respect to making sure that the facility gets paid fully and finally or fully, which may be to the detriment of the family, certainly with respect to the complication of Medicaid applications, whether it's a disabled child or many other, a caregiver in place. So there are examples that I believe a fair amount of elder law attorneys encounter and have heard where there are issues that come up through this process.
Thank you. And another area that I know there's misinformation and issues is that even with the Department of Social Services itself, if there's a community situation, family, husband and wife are going to look for community-based services, or for that matter, anyone, and they might be within asset limits but because income exceeds the income threshold, they'll get denied, despite the fact that there's a pooled income trust that's available for individuals to reduce the income to within program limits. So in essence, people can get turned away not knowing where to go because there are wrong doors at the DSS. Would you find that in your practice that does occur?
Thank you, Senator Kelly. Yes, and the issue with respect to availability, that's the whole issue of an informed choice. I didn't know that, would say some folks who didn't know. And that's the very point of an informed choice. I didn't know that. And had I known that, would I have done something differently to that point, Senator Kelly?
Thank you. Is there anything else you'd like to say to the committee? Actually, I guess that's my third question. I apologize. I quit on that one.
I think Attorney Lang, Attorney Rubin, and others, and even the report from the task force, I mean, Mr. Barrett was even on it. I see he'll be testifying after, comes up with a lot of suggestions. So I'd respectfully request, to the extent you have time, to look at Attorney Lang's comments, Attorney Rubin's comments, Attorney Wilson will be speaking, and then also reading the recommendation by the task force.
Thank you very much. I apologize for the third question.
Thank you, Senator Kelly, and thank you, Mr. Perry, for coming today and testifying and sharing that information. Is there any other questions?
Oh.
I didn't see any hands up. Thank you.
Thank you all. Be well.
Up next, we have Matt Barrett, followed by Cheryl Rosenbaum.
Hey, good afternoon, Senator Miller, Representative Garibay, Senator Fazio, Representative Wilson, and to the distinguished members of the Aging Committee. My name is Matt Barrett, and I am the President and CEO of the Connecticut Association of Healthcare Facilities. And thank you for this opportunity to testify on several bills being heard today. The first being House Bill number 5310, an act requiring nursing home facilities to spend at least 90% of Medicaid funding provided by the state on direct care. We are opposed to this bill because all 5 of the cost components used in setting nursing home rates are essential, and mandating 90% of Medicaid funding be spent on direct care would unsatisfactorily leave only 10% of the overall Medicaid funding for all other nursing home services and supports. We also oppose the additional reporting proposed in the bill. We find it duplicates the considerable reporting and oversight that nursing homes now produce and report to DSS. Next bill, House Bill 5311, an act encouraging socialization for nursing home residents by providing transportation for visits with family. We support the bill and once more acknowledge Representative Kathleen McCarty's longstanding advocacy for this measure and urge the committee to adopt it. Next, House Bill 5313, an act concerning temporary price controls on services provided by temporary nursing service agencies. We support this bill as accountability, continuity of care, and overall quality is suffering as labor prices are soaring for our Connecticut nursing homes due to the practices of nursing pool agencies. We urge adoption of the substitute language in the bill, which I provided in my written testimony, and it essentially just moves the September implementation of rate caps in the bill to July 1st, 2022. And I've, again, on behalf of my association and as a member of the Senior Fraud Task Force, I'm pleased to support the provisions in Section 4 of House Bill number 5314, which is an act deterring fraud and abuse perpetrated against senior citizens. These provisions would provide an elderly person with assistance completing a Medicaid application who is not related to such elderly person by blood or marriage to disclose any affiliations, business relationships, owner interests, or employment with any other business or entity that may be bill Medicaid for services provided by such elderly person. I also recommend substitute provisions in this section as well. I refer to them as a friendly revision that conforms or makes consistent some language in Section 5 of the bill. And then finally, on House Bill, Senate Bill 265, an act concerning notice of staff to patient ratios, room telephone access, and asbestos mitigation measures at nursing facilities. We do oppose these provisions as well. These are unfunded mandates on Connecticut nursing homes. Additional reporting requirements at a time when nursing homes are struggling with probably the historic, the most historic staffing shortages ever experienced in the sector. And we oppose those provisions for those reasons. Again, thank you so much for the opportunity to testify, and I'd be happy to answer any questions that you may have.
Does anyone have any questions? Seeing none, thank you so much, Mr. Bear. Oh, here came one. Senator Kelly.
Thank you very much. And thank you for being with us here this afternoon, Matt. I do appreciate it. I have a couple of questions. Is it true that the average wage for an LPN from the healthcare agency is $50 an hour?
First of all, good afternoon, Senator Kelly. I'm going to be very careful and cautious about answering that question. And that is that I've been advised on so many occasions that my association of 151 skilled nursing facilities should be very careful about collecting and doing surveying of wage data amongst employees and including the staffing agency. So I've been very cautious about doing so for antitrust reasons. And even though I do want you to know in a sincere way, I would never be gathering that information for anti-competitive purposes or to suggest that wages could be fixed or artificially suppressed in some way. I don't know the answer to the question purposefully, which is why in organizing, if I've done that, other representatives from our skilled nursing facilities to present testimony to the committee at a similar bill regarding staffing agencies. I asked them to present that information directly, and several will be doing so today. So I apologize, Senator, I don't know the answer.
Okay. Before I ask my next question, Madam Chairwoman, can I go past the 2-question cap? Or do I have permission to go beyond the 2-question cap?
Are we talking 3?
I'm not going to be spending all afternoon on this, just a couple to get a couple of key and salient points, because I heard what 1199 said. And I think it's important that, when we're dealing with human services, that we compensate labor adequately. But I want to get some information on the record from the industry at the same time. So I'm going to go past the 2 questions if that's appropriate.
Okay, we'll let you have your other question. We'll let someone else go first if they want to, and then we'll go back to you for another question, okay?
Okay. So are the other questions now or
yep, right now?
Okay.
Do you have a question right now, Senator Kelly?
Yes. Matt, the Medicaid reimbursement rate for the long-term care facility rate, isn't that capped currently at $13,863, I believe, per month? Well, that's the current DSS rate. I hate to ask you a question like that, but just correct me if I'm wrong, but Medicaid already caps the monthly fee that a nursing home gets.
Absolutely. Thank you so much for the question, Senator Kelly. Absolutely. We have a prospective cost-based reimbursement system where facilities annually submit cost reports, auditable, verifiable costs, including profit and loss statements, by the way, of related parties. I think we may be one of the only states in the country that require it of our nursing facilities. And so the entities discussed in previous testimony all are required to, when they have a relatedness to the nursing home, must submit their profit and loss statements. And incidentally, those costs that are above market conditions are disallowable under the Connecticut rate setting system. But all of the cost categories in the rate setting system, from the direct care costs, and Commissioner Gifford's testimony, I think, really enumerates this and spells this out very well, are all subject to cost caps. And so this system is highly regulated and artificially capped across the system, so much so that nursing homes, and this has been studied endlessly, have been determined year after year to be being paid Medicaid rates that are up to $25 a day less than the actual cost of providing those services on a per day basis. And so we find a lot of cost shifting going on when you're suffering those kind of losses in the Medicaid program, and principally nursing homes mitigate those losses through their Medicare business lines, providing rehabilitation and therapy to Medicare recipients. And the private pay market that used to be, a big part of the nursing homes business model is now lost to people are spending down in home and community-based environments, their resources appropriately, or in assisted living communities. But I appreciate your question very much. All these costs are capped artificially, though it may be, and subject to audit, and there's profit and loss statements disclosed every single year concerning related parties.
Okay, so what I think I heard you say was that basically the Medicaid line is capped, but the private market, private rates are not capped. And that's where you do your cost shifting from. So, I know in my region down here in the greater Bridgeport area, you're looking at almost $600 a day, which is over $18,000 a month, private pay, but state's paying only about $13,000.
If I could interrupt just, Senator, on a daily basis, the average Medicaid per facility, I think it may shock certain members. It often shocks people. It's $250 per day. And in fact, related to the proposal that 95 or 90% would be earmarked towards direct care, that would mean $25 were available for laundry, housekeeping, recreation, food. I think breaking it down or deconstructing that way is quite illustrative. It's $250 per day on average.
And what is the cost of care that's delivered on average? The actual cost?
It's going to depend facility, and it's another component of some of these bills. We're moving towards an acuity-based, component in the direct care part of the rate setting system, where nursing facilities are going to be reimbursed based on the acuity of the residents they're serving. And so more complex care, higher acuity residents will associate with higher reimbursement rates, and those with lower reimbursement rates. So it's not really a one size fits all across the entire sector. I really use the $250 example because that's the average nursing home rate, but many nursing facilities receive rates below and above. Generally on the Medicaid line alone, though, we can virtually say that everyone is delivering services at a cost that is higher than their rates.
Can you tell us an idea of what the average census of Medicaid recipients are in the nursing home industry?
It is the lion's share of Connecticut's nursing home population, Senator Kelly. It's about 74 and perhaps even higher as a result of the pandemic, the percentage of actual Medicaid recipients that make up the overall population of the facility. It's about 74%. And that's an especially important question today when, pre-pandemic nursing home occupancy overall was close to 90%, 89, 90%. And while we are doing very well in Connecticut or galloping towards recovery, although it's still quite a ways away, and I think that the Delta and the Omicron variants were big setbacks, as you know well, for Connecticut nursing facilities. But today we're even at 78% occupancy, which is about 6 points higher than the national average. But the lion's share is Medicaid, and that's why there's always a reaction. And perhaps, I always am concerned. I've testified before the legislature so many times that it's sometimes perceived as an overreaction when there is just a very sensitive dial to all these new requirements and increased costs associated with them. When the lion's share of nursing home residents in Connecticut, who perhaps have spent down their resources and are impoverished now, are being borne by Medicaid, and none of these costs are reflected in those rates.
And my last question, If this 90% is imposed, will nursing home facilities, which occupy a very important place on the chronic care continuum, will any facilities close?
Well, I try not to be given to too much drama, Senator Kelly, but to require the mathematics to the 90% proposal just don't work in any way, shape, or form. And so there would be a collapse in the system, in my view, if that were ever to become law. And related to the neighboring states who have done that, one of those, the New York situation is currently being challenged in the courts. The other state that we're moving through a regulatory process, some of the provisions are being walked back. I really would highly recommend that Connecticut watch this experience of our neighboring states before we jump into the fire on this and contribute towards the, destabilizing more and more Connecticut nursing homes in an environment where they're significantly challenged moving towards the other side of this COVID-19 pandemic. I appreciate your questions very much.
Thank you, Mr. Barrett. And thank you, Madam Chairwoman, for giving me the latitude to ask those questions and the committee for their indulgence. Thank you.
Okay, thank you, Senator Kelly. Does anyone else have a question for Mr. Barrett? Seeing none, thank you so much for coming and testifying today.
Thank you very much.
Up next, we have Cheryl Rosenbaum, followed by Liz DuPont Deal.
Welcome, Cheryl.
Good afternoon, Representative Garibay, Senator Miller, Senator Fazio, Representative Hughes, Representative Wilson, newly appointed and esteemed members of the Aging Committee. My name is Cheryl Rosenbaum, and I'm the coordinator of the Caring Connection Adult Day Health Center, an enterprise fund of the town of Windsor, Connecticut, serving the towns of Windsor, Windsor Locks, Bloomfield, East Windsor, and the north end of Hartford, and at times serving clients from other nearby towns, including Suffield, Manchester, South Windsor, and East Granby. The Aging Committee won the lottery with recently appointed Chair Jane Garibay because of our love for our elderly citizens, those who made it possible for all of us to be here today. The town of Windsor and District 60 know firsthand of Jane's dedication to aging. The Connecticut Association of Adult Day Centers are indebted to her for bringing this vital issue forward for our most frail elders and for their future well-being. Thank you very much for the opportunity to speak today about House Bill 5312. Currently, adult day centers are one of the covered services in the Home Care Program for Elders Waiver Program and under the regulation of DSS. Also, our programs are utilized by families on the statewide Alzheimer's Respite Program. Adult day services are presently available to adults 65 and older under the Medicaid state plan and some 1915C home and community-based service waivers. Today, I implore you to consider that this service be made available to all Medicaid recipients. Adult day centers are community-based support programs for elders who choose to remain at home in their communities, delaying costly long-term care placement at a fraction of the cost. Daily adult day centers provide clients health monitoring, supervision, activities, companionship, socialization, nutritious meals and snacks, medication administration as needed, client and caregiver support, and door-to-door transportation at the current reimbursed rate of $74.74. I strongly believe in the motto of my center, which proclaims, "We can change how you live, not where you live." Nothing could be more accurate with regard to the past 2 years. Adult day centers helped maintain independence, significantly reduced isolation, and increased socialization for those who attended. So many of our clients were unable to be with any others during the pandemic, but every day at our centers, they were safe, cared for, active, socialized, and engaged in meaningful activity. Isn't that what everyone, regardless of their age, wants from life? Isolation in the elderly can have dire consequences. It can lead to depression, going without necessary care, medication inconsistencies, and lack of good nutrition, just to name a few.
Ms. Rosenbaum, your time is almost up.
For caregivers who choose to care for their elderly family members, success is directly attributed to their health and well-being. We provide much needed respite for those caregivers, making it possible for them to take care of themselves and become the best caregiver they can be. I and my colleagues know that there's no greater feeling than to experience the joy of elders happy with their lifestyle choice, being part of our communities, and the knowledge that we and our devoted staff have made it possible for their caregivers to honor that choice. We and now you know that our programs are there to support and ensure safety and peace of mind to both client and caregiver while keeping our elderly in our communities. Thank you for this opportunity to speak.
Thank you, Cheryl. And I am honored to be part of this aging committee with so many dedicated senators and representatives and staff members. So thank you for the kind words for all of us. Rep. Belinsky, do you have a question?
Thank you, Madam Chair. I have less of a question and more of a personal experience to just convey the availability of these adult daycare centers is critical to aging in place. And I personally have experienced the benefits of having both a father and a father-in-law well cared for in facilities such as this. So I am in strong support, and I thank the good woman for her testimony, and also all of my colleagues for everything that we've done in support of this care option. So thank you very much, Madam Chair.
Thank you, Rep. Belinsky. Does anyone else have a question? Cheryl, can you tell me, I forget the exact amount, but how many of the elderly that attend your facility live at home with family?
Almost all of them in my particular facility. However, across the state, we have many facilities, and there are some who live in the community, and it is this service that can keep them actually independent in their home with the service of adult day centers and sometimes some other supportive care.
Because I would assume those that are with family members work, right? So this allows them to keep their elderly at home.
Yes. It could be that they are cared for by a spouse who needs the respite, or children, nieces, nephews, grandchildren who have had to return to work and can do that with the peace of mind that their family member is safe and cared for in our adult day centers.
Right, and for the money, I know that, they have transportation is included in that $74. They get 2 meals, but you have a nurse on staff for medical needs, from showering to all kinds of different services for that $74, right?
Yes, that is true. And I know you'll hear from a few of my colleagues on the board, but we do have nurse, CNA, program assistants, nutritious food, all of that as part of the everyday program.
Okay, and just one last question, and I'm also doing a little bit more. So it's true that 3 of the facilities are closing or are closed. So that's the danger that we face of losing how many are there across the state?
So right now, I believe we have 36 paid members. We are down over the last years, and there's the possibility of 2 or 3 still to close this year.
Okay, thank you.
You're welcome. Thank you.
Seeing no one else, there's Senator Miller, please.
Thank you, ma'am. Cheryl, forgive me if I didn't grasp this from your testimony. How would this bill 5312 benefit the adult centers?
So currently, the only way someone who is receiving Medicaid benefits can access our program is if they are part of the waiver program through DSS. We want anyone who is receiving Medicaid benefits to be able to access the service of our program.
Okay, so you're saying that it's only if you're a part of the waiver, that's the $74, that you would have you would receive money. So if I'm a person, an aging person, living at home, not in a healthcare facility, a long-term care facility, and I'm not included in that waiver, and I attend your facility, are you saying that the facility has to assume or some of the cost, absorb some of the cost of me coming there, or the transportation of me getting there?
So if you are not on the waiver program through Medicaid, you're a private pay client. Medicaid does not pick up any of the cost.
And so I'm just for transparency and clarification for those that are watching. So this bill will help me, who's not included in the Medicaid waiver. So you want to provide transportation for all seniors, or I'm sorry, I'm trying to get away from the term, for all older adults that attend your program.
No, we want to provide this service, which includes transportation, to Medicaid recipients. We want them to be able to go through their physician to be able to access this program. We want to work with DSS and try to clarify future considerations for transportation. But right now, what we're asking is that Medicaid recipients be able to access this program if they are not on the waiver program. Have I made it clearer?
I just want to make sure that I'm getting it. So, Madam Chair, she asked me a question. So the way it's set up now, not all Medicaid recipients receive transportation or paid by DSS, correct?
No. The way it's set up now is not all Medicaid, or not all individuals on Medicaid can access our program. The only ones that can access our program are those who are in the waiver program through DSS. We are trying to be able to have Medicaid recipients access our program.
So how are those? I'm sorry, madam, whenever, second round, I'll wait.
I don't see any other hand up at this moment, so continue, please.
So those participants that are not a part of the Medicaid program, the waiver program, how are they receiving your services? Are they receiving your services? Are you paying for the services out of your pocket, out of other resources?
Well, so generally they are not receiving our services unless we can figure out a way to get them onto the waiver program, which is not the typical thing that happens. They are not receiving our services because typically they can't afford them.
So are you saying that that person or those individuals are probably sitting at home, and these are the individuals that are aging at home?
They're either sitting at home or they end up in nursing homes where care is much more expensive.
So, and
then they have to, I'm sorry, and
no,
then
go ahead.
Then they're leaving their communities, their homes, their families, who if they could access this kind of program, they could remain active in their home with their families and in their community, as opposed to the state paying for long-term care.
So, Madam Chair, if I may make this comment, thank you for that. And I'm sorry for the line of questions. I want to make a point.
Thank you.
I heard you say that you're getting, or heard someone mention that you get $74 from Medicaid, from DSS.
Correct, $74.74.
$74.74 for someone that's in your program, that's aging at home. And you mentioned that if they're not in your program, either they're at home being inactive, or they may go into a long-term care facility. And I heard in earlier testimonies that Medicaid paid $250 for a recipient, a patient that's in long-term care. Now look at the math, what we're paying. And that's per day. I thought I heard per day. And so look at the math and look at the monies that we're spending where we could have be saving, be preventive. And that's what we need to do more of. We need to take more preventive measures in making sure that, patients are, I should say, the elderly are staying at home and not forcing them into long-term care facilities. So thank you, Madam Chair.
Representative, can I just make one last comment? Thank you.
Sure, go ahead.
We want our elders to have choice. We want it to be their choice of how they live out the golden years of their lives. We want to honor them and their choice. Adult daycare can do that.
Yeah, thank you, Cheryl, and thank you all that you all do with your leadership at the Caring Connection.
Thank you.
Madam Chair, Representative Belinsky has his hand up.
I'm sorry, I didn't see that. Thank you, Senator. Representative Belinsky.
Thank you for the second time, Madam Chair. You know what? The senator's observations are so incredibly good, but I have to add something to it. Not only is this a cost savings for the state and for our social programs, but that it is such a superior experience for our elders to be able to go someplace and be engaged and actually enjoy their day, much more so than a permanent living situation where routine just sort of rules the day. There's something to be said about either climbing on a bus or having your loved one drop you off and pick you up and talk about your day. It's very, very reminiscent of the types of experiences that young parents have with their children as well. So it's more than just a cost savings. It happens to be a real life enhancement. So I'll get off the soapbox, but I mean, I really believe in this. And Ms. Rosenbaum, thank you so much for what you do and for letting us know the status of facilities around the state and that we're in danger of losing so many as well. That's frightening. So thank you very much, Madam Chair.
Thank you, Rep. Belinsky. Senator Miller.
For the last time, Madam Chair, and Representative Belinsky, I want to join you on the soapbox because not only is it a cost saving, but these family members come back home to their families each night. And that's important to them. Coming back home to their loved ones and not sitting in a facility waiting for their loved ones to come to them. So again, thank you, Cheryl, for the work that you and your organization do for the people in our state. Thank you. I should say that the older population in our state.
Thank you.
Okay, up next we have Liz DuPont Deal, followed by Kelly Ryan.
Good afternoon, Senator Miller and Representative Garibay, Senator Lopes and Representative Hughes, and to all the members of the committee, and welcome and congratulations to Representative Khan. My name is Liz DuPont Deal. I'm with the Connecticut Citizen Action Group, which for 50 years has worked to change the relations of people to power and to ensure quality healthcare for all people. CCAG is a member of Recovery for All, and I live in Windsor, which is well represented today. On behalf of CCAG and our thousands of members, I thank you for the opportunity to testify on SB 260, an act concerning Prescription Drug Cost Control Board, and to offer suggestions for improving it. Connecticut residents are struggling to pay for healthcare. We hear industry sectors, hospitals, pharmaceutical companies, and insurance companies all blaming each other for the rising costs we experience. Certainly, each of these sectors extract billions of dollars for profits, stock buybacks, and executive pay at the expense of patient care. Patients need much greater protections from the pharmaceutical industry's greedy practices. Senate Bill 260 has the potential to provide this for Connecticut residents. A July 2021 report by the U.S. House of Representatives Committee on Oversight and Reform examined financial data for the world's largest 14 drug companies. This report is attached to my testimony. It finds that, quote, leading drug companies have spent more on stock buybacks, dividends to investors, and executive compensation than on research and development. Specifically, from 2016 to 2020, they spent $577 billion on stock buybacks and dividends, $56 billion more than they spent on research and development. In the same period, compensation for the 14 companies' top executives totaled $3.2 billion, representing an increase of 14%, while they also raised drug prices for millions of Americans. Finally, spending at drug companies described as research and development is often actually designed to suppress generic competition and to maintain monopoly prices. According to Open Secrets, the Pharmaceutical Research Manufacturers of America spent roughly $8.6 billion in lobbying in the first quarter of 2021, and the pharmaceuticals and health products industry spent $92 million, more than any other industry. In closing, we support modifications recommended to this bill by the Universal Healthcare Foundation in their testimony and by the Office of the Healthcare Advocate to strengthen the board's authority and to better address conflicts of interest. We want to thank the committee and the administration for this bill and for your work towards addressing the out-of-control costs of healthcare, including prescription drugs. Other states are implementing boards with authority to set upper price limits, and there is much we can do to actually control the cost of drugs. CCAG and our members and allies welcome the chance to work with you to help make Connecticut a leader in making healthcare more affordable for our residents. Thank you for this opportunity to testify. I welcome any questions.
Thank you so much, Liz. Does anyone have any questions? Thank you so much for your testimony. As we know, it's a very important issue for all of us to have affordable health care for all people, and we appreciate your coming today.
Thank you for your time. Take care.
Thank you. Okay, bye-bye.
Up next, we have Kelly Ryan, followed by Ann Wilson.
Thank you. Members of the Aging Committee, my name is Kelly Ryan, and I'm here today on behalf of the Pharmaceutical Research and Manufacturers of America. We represent the innovative biopharmaceutical companies that develop new medicines for patients. A number of our members have an important footprint here in Connecticut. I'm here to respectfully oppose Senate Bill 260. This bill sets prices throughout the supply chain, but does nothing to address patients' biggest concern: out-of-pocket costs. The unpredictability that patients feel is often tied to insurance plan design. They shoulder a considerably higher burden of costs for prescription drugs as compared to other services, and they may be charged the list price during a deductible or a coinsurance when often the plan is paying considerably less. In fact, the narrative that prescription drug prices are increasing dramatically or a major driver of spending is misleading. The average net price of brand medicine has grown in line with or below the rate of inflation for the last 5 years. And in 2020, average brand net prices declined by 2.9%. But this is not at all what patients are feeling at the pharmacy counter. We share the desire to make sure that patients can get the medicine they need when they need it, but this bill is just not the way to do that. Instead of helping access, this bill threatens it in a number of ways. Patients in countries that have price controls have slower access to fewer innovative medicines. And the idea that price controls will not negatively impact innovation is false. The science is getting harder, clinical trials are more complex, and the need to pivot quickly has been especially clear in these past 2 years. Our members invest approximately $1 of every $5 in R&D, one of the highest R&D intensities of all industries. In 2018, Connecticut passed broad reporting requirements in manufacturers, as well as a look at other supply chain actors. This bill is unnecessarily duplicative of those efforts, along with the benchmarking efforts that are currently underway. And then it goes much further to raise serious legal concerns. While it's true that some boards have been established, this bill goes far beyond anything that currently exists. The bill envisions price controls throughout the supply chain. This is a transaction that most often takes place entirely outside of the state of Connecticut, which raises dormant Commerce Clause issues. And no state has established an upper payment limit of this sort. Also, with respect to patented medications, this approach raises federal preemption issues. There are more meaningful solutions, and we're happy to be at the table to continue to work towards them. Benchmarking efforts that look system-wide, like legislation being considered this session, can be an important step to truly understanding cost drivers. Massachusetts has had such a program for a number of years, and pharmacy was the only major category at or below the benchmark in 2020 and has been in line with or below other spending categories for a number of years. Instead of imposing arbitrary and likely impermissible price controls on one element of the supply chain, Connecticut should focus on patient-centric approaches that help at the pharmacy counter and don't threaten access or innovation. I'm happy to take any questions you may have.
Thank you. Are there questions from the committee? Kelly, I have a question. You said that it would threaten access. Can you explain that?
Yes, absolutely. So in looking at countries that impose price controls like this, that do it nationally, they have slower and reduced access to medicines. For example, in the US, we have access to nearly 90% of all medicines that have been launched between 2011 and 2020. 64% are available in Germany, 60% in the United Kingdom, and 46% in Canada. So the medicines that are coming to market, namely the really cutting edge medicines, are not available to patients in those countries as fast or at all.
And do you know why why they're slower in those countries? Because of the price controls. Mm-hmm. Okay. Are there questions? Thank you for your answers. Are there questions from the committee? All right, Kelly, thank you for testifying today on behalf of this bill. Appreciate it. Thank you.
Up next, we have Ann Wilson, followed by Paul Pescatello. Ann Wilson, are you with us? I do not see her right now. So Paul Pescatello, followed by Maria Hitchcock.
Hi, good afternoon. So again, my name is Paul Pescatello. I'm senior counsel at the CBIA, and I'm also executive director of its Bioscience Growth Council. I'm here today to speak in opposition to Senate Bill 260, an act concerning a prescription drug cost control board. 260 reflects a laudable goal: how to assess and how to address the affordability of drugs. Unfortunately, we believe the bill is flawed in three respects. First, the focus of the bill is too narrow. Drugs are only part of the overall healthcare cost equation. They represent about 15% of the equation. For each healthcare dollar spent, only 15 cents is attributable to prescription drugs. That share of the healthcare cost pie has been remarkably stable, 15% since the end of World War II, almost 75 years ago. So there are many, many factors in the healthcare cost equation: surgeries, short and long-term care, hospitalizations, doctor's visits, to name only a few. Second, many of the bill's key terms are at best vaguely defined. SB 260 would establish a prescription drug cost control board together with a prescription drug affordability stakeholder council. These groups would assess whether the price of a prescription drug represents a quote unquote affordability challenge. If such a determination is made, the control board would recommend a quote unquote upper payment limit to the insurance commissioner. Both terms, affordability challenge and upper payment limit, are not defined in the bill as it's currently drafted. In addition, and again, as the bill is currently drafted, whether the insurance commissioner has the power to impose price adjustments on biopharmaceutical companies is open to question, if not unlikely. Another unaddressed issue in SB 260, the bill ignores how state government imposed price controls could be implemented given a core principle of patent law, one of which is to grant patent holders exclusivity on the economic value of the innovations they create during the life of a patent. Finally, and really most importantly, the bill would essentially layer a price control board and price controls over the life sciences and the biopharmaceutical industry. In so doing, SB 260 ignores the long history of government-imposed price controls. An academic, private sector, or government-sponsored study demonstrating the effectiveness of price controls does not exist. No matter the product, flour, machinery, medicines, price controls cause shortages, delays in the introduction of new products, and incentivize actually the introductory high prices. When tried, all price controls have done is ratchet up the misery of empty store shelves and metastasizing inflation. Applied to medicines, they translate into
Mr. Pescatello, your time is almost up.
Oh, thank you. And slow or non-existent introduction of new cutting-edge therapies. The main thing I guess I would conclude with is that the core problem with 260 is that it undermines our key strength in Connecticut, which is the biopharma innovation. We don't want to mess that up and all the economic development investments we've made in that industry. So with that, I'll conclude my remarks. You have my written testimony, and I'm happy to answer any questions you might have.
Thank you, sir. Are there questions from the committee? Okay, seeing none, thank you, Mr. Pescatello. We appreciate your testimony.
Thank you.
Up next, we have Maria Hitchcock, followed by Jill Zorn.
Good afternoon, Senator Miller, Representative Garabee, and members of the Aging Committee. My name is Maria Hitchcock, and I'm the Director for Daybreak at Hartford, Adult Daycare Program in Hartford. I'm also speaking today as the President of the Connecticut Association of Adult Day Services, also known as CAADS. I appreciate the opportunity to testify and speak in strong support of House Bill 5312 and that concerning Medicaid coverage for adult day services and transportation to and from such services. One of my colleagues, several of my colleagues are here today, and one has already spoken and will share facts and details in support of this bill. I'm here today as president of the association and to voice in full support of the proposed legislation and to provide you with a basic overview of the wonderful services provided by adult day centers that are certified by CADS, although I do recognize that many of you are already familiar. Adult day services, center services are a full day of care that includes supervision, activities, companionship, socialization, and assistance. Medication administration by a licensed nurse, health monitoring at our medical models, health monitoring, assistance with ADLs, nutritious meals, including breakfast, hot lunch, and a snack, and continuous encouragement of liquid. Bathing and showers are available and personal care is provided. Caregiver support, information, education are readily available, as well as reinforcing teaching done at their doctor's office. Escorted transportation to the door is provided to and from the center. Assistance with coordinating and planning the client's long-term care needs is available. Coordination with physicians, specialists, and family members. Community engagement, opportunities for elders to connect with their community through the center. Organized out trips, programs brought into the centers for philanthropic work and socialization with other clients, their families, friends, and visitors. Opportunities for daily face-to-face individual consultations, information, and referral support and assistance. The current people that are able to attend our program are 65 and older and on the Home Care for Elders program. So if someone is 61, 62, 63 and have the critical needs, they are getting services under Medicaid. Through PCA, visiting nurse, very much more costs bearing services, which we provide for the 7474 per day, and more continuity as we get to see these clients every day. Adult day centers are a wonderful option for families, and I know very well because I was first introduced to the service 22 years ago when my grandmother began to attend the center. As a registered nurse, I had not known about the service. It's, as many have said, the best kept secret, but I immediately fell in love with it and have now made it my profession for 22 years. Individuals that would come on already are having they have these critical needs and are already getting these critical needs paid for by Medicaid. So it would be a cost neutral, if anything. They get PCA services, visiting nurse, they get Meals on Wheels, they get.
Ms. Hitchcock, your time is almost up.
So thank you for raising this bill and hearing our testimony. We firmly believe that this bill will result in cost savings for the state and offer valuable choice for seniors in our communities and to receive these much needed services. It's very much person-centered, personal choice, taking into account equity and its cost saving. And I would be happy to answer any questions.
Thank you, Ms. Hitchcock. Representative Hughes.
Thank you. Let me make sure I got. Thank you, Ms. Hitchcock, for your testimony about the incredible service that adult day programs provide. And I don't know that all of our public understand that they're right within the community. Would you consider this updating our Medicaid reimbursement to what the services that are needed in terms of home care are now? Or, you know, tell us how that has shifted over the course of your being the president of the association.
So it's not really changing our cost because our rate of $74.74, we're not asking for any additional rate. We're just asking to open it up so Medicaid recipients can participate. Currently, if you're on Medicaid and you have visiting nurse, PCA, and have these services in the home, you cannot have the choice of coming to adult daycare, and you don't get the advantage of socializing. So.
Right. So it's actually perpetuating the isolation of seniors, which we saw was so devastating during the pandemic. Now that we're opening up and coming back.
And also during the pandemic, we were able to maintain, you know, many of us closed for a short amount of time, but we were able to maintain our clients coming, and they actually fared better. We had no outbreaks in adult daycares. You didn't hear anything about us in the news. Our clients were actually fared better when they were coming because the ones that were at home, again, have the critical need. So they had home services coming into the home. And here, you know, we have the infection control and, you know, maintaining the distance. And we don't have the client feeling so comfortable that they were at home to take the masks down. But yes, through COVID, it was challenging. And definitely we saw our clients. I had over 50 clients end up, you know, discharged, nursing homes, passed away, which we always have clients leaving, but not in that amount during COVID. And the ones that did stay home ended up, you know, non-mobile. They just progressed, or, you know, especially Alzheimer's, dementia, with not having the interaction, like someone said, about getting on the bus, going to school, you know, going somewhere and having something to come home and talk about and just be around, even if it's just to complain about how awful it was and how bad the food was, or, you know, of course, it gives them something to get up for, get dressed and go, instead of just being home.
And if you did accept Medicaid reimbursement for adult day, what's your capacity like if you've got all these new people that want to come?
So many, because of what's happening, you know, many in our industry are, you know, I can speak for my center, you know, I'm only at half capacity. There are some new adult day centers that have entered. It would be, as people need to come back, it's also an issue because we were 52 adult daycares, we're down to 36 and they are going down. So I believe, and, you know, my colleagues could better speak, that we all have we have room and capacity.
That was my suspicion. I just wanted to verify that with you. Thank you so much for your testimony.
Thank you for your questions, madam. Are there any other questions or comments from the committee? No, thank you, Ms. Hitchcock, for joining us today and sharing your testimony.
Up next,
I'm sorry, before you call the next person, Cameron, I just wanted to make a small announcement that if we miss someone, or they signed up and they didn't get the opportunity to testify, you will be able to testify at the end of the public hearing. And so please stay tuned. Thank you.
Thank you, Senator. Up next, we have Jill Zorn, followed by Andre Brell.
Thank you very much. My name is Jill Zorn, and I'm Senior Policy Officer at Universal Healthcare Foundation of Connecticut. Thank you to the co-chairs and members of the committee for the opportunity to testify. I'm here today because prescription drugs don't work if people cannot afford them. That is why I'm speaking up on behalf of our foundation in support of SB 260, an act concerning a prescription drug cost control board. This important piece of legislation has the potential to make a difference in the lives of Connecticut residents, too many of whom are cutting pills in half, skipping doses, or not filling needed prescriptions, all because they can't afford the medicines they need to maintain and improve their health. I'd like to start by pointing out that the top recommendation of the Healthcare Cabinet in their 2018 report on pharmaceutical cost containment strategies was to create a drug cost review board. Universal, through our president, Francis Padilla, was a leader in the development of that recommendation. Now it is 4 years later, and it is long past time to take this important step, as several other states, including Maryland and Colorado, have already done. While the federal government is stalled on efforts to lower prescription drug costs, the states must move forward. As drafted, SB 260 provides a great start, but it is in need of some changes if it is to have the impact we'd like to see. Overall, the board must have the authority to make decisions and to enforce those decisions, not just to make recommendations. It must have the scope to set upper payment limits for all types of entities, not just health plans, and it must be free from conflict of interest in both board membership and funding. Contrary to what opponents might wish you to believe, this legislation is not about setting manufacturer prices, and it's been very carefully crafted to not have legal challenges that are kind of being implied in some of the testimony today. For clarity, it's important that the bill refer to costs or upper payment limits and not necessarily prices. We've submitted written testimony, which provides more detailed recommendations. Because this type of a bill it's evolving across the country, and it can be somewhat technical in nature, we've attached an outline of model legislation to our testimony, and we suggest the committee consult with Jane Horvath, the expert who drafted the original model legislation, and she actually submitted written testimony on this bill. And she could be very helpful. Again, Universal is grateful to the co-chairs and members of the Aging Committee for raising SB 260, which adds Connecticut to the growing list of states that are pursuing this crucial policy. We support the bill in concept and ask that you consider making changes to strengthen it. Thank you.
Thank you, Jill. Are there questions from the committee? Just one quick one, Jane. Jill. There was earlier testimony from the pharmaceutical industry that this bill would threaten access and slow down the availability. And so do you have any comments on that, or have you heard those comments made before?
The pharmaceutical industry makes those comments every day when they're opposing anything that is approaching trying to get a control of prescription drug costs. I don't believe at all that it threatens that in any way. Many of the drugs that are likely to be targets of a prescription drug board like this are products that have been in the market for years and are still incredibly expensive, I think, and actually growing in price. I think you're going to hear from the National MS Society a few people after me, and they probably have some great examples. I used to work there, and the same drug that when I worked there, I don't know, cost maybe $1,000 a month. I think now costs about $80,000 a year, the same drug. So I think there's a lot of room for making changes. Obviously, healthcare costs are out of control in many sectors. There's a lot of work being done on the hospital industry right now. But there's definitely, this is a bill that could really help with prescription drug costs.
All right, thank you very much for testifying before us today. Have a nice day.
Up next, we have Andre Brell, followed by Holly Gedita Deming. Andre, are you there?
Yes, I'm here. Sorry about this. Let me put a video on. Okay, sorry about this. I apologize. Good afternoon, Senator Miller, Representative Garibay, and members of the Aging Committee. Before I start, I would like to congratulate better half, beautiful half of our society, today's International Women's Day. I wish you the best. Today's beautiful March 8th, International holiday. Like I said, my name is Andre Brel. I run Juniper Home Care, and Juniper Home Care is agency provide homemaker companion, PCA services, Meals on Wheels, adult family living, home modification, moving services, all a spectrum of continuum of care. But most important today, and why I'm here, we have 4 adult day centers in Hamden, Connecticut, New Britain, West Hartford, and Hartford that help our elderly people, citizens of Connecticut, with everyday needs. Today here, I represent the association where I'm board chair, advocacy board, and I also past president of the association. And I'm here in a strong support of House Bill 5312, an act concerning Medicaid coverage for adult day services and transportation to and from services. As I mentioned, Juniper does all these homemaker companion, traditional home care services, and as well as the adult day. For me, as a president of my agency, obviously I have to be not biased, even for all services. But I have to admit I am biased because adult day services is my baby, and I always in the strongest support for this. And the reason for this is simple. It's a humane service, it's beautiful service, but it's also very, very very money consuming, money anxious service. For 74, as you heard today, we offer all services that I mentioned, like a la carte under one roof. We have a nurse who administers medications. We have transportation to and off. We have 2 meals. We have recreation activity, exercise, whatever everything you think about, we offer under in our centers. And in my case, a couple of my centers are very culturally oriented. I have Spanish speaking. I have, as a matter of fact, I have Ukrainian speaking right now, which is very, very big topic. And I don't know what my clients or my staff would do if they don't have this opportunity to talk about it and to share their grief and their concerns what's going on in the world right now. That's why, but you can apply this not just for my centers, it's for all centers. It's only 26 left. I think it's going to be less because we are under very, very strict, under inflation. You see the prices of gas, prices of food. It's concerned every industry, but for us, it's because we are offer everything. It's like triple and fourth, and everything is on us, and we feel it. We feel this pain.
Mr. Burrell, your time is almost up.
My time is off. I understand. I apologize. I'm a little bit more emotional. But anyway, in conclusion, I like you, and I praise you and thank you for supporting this bill. My special thank you, Representative Garibay, because she is what she did. She heard about the concerns. She reached out to us. She immediately, within a few days, she organized the meeting in Windsor. She listening to us, and look, we are here. It's unbelievable. This is what we expect from our representatives, expect from our politicians. And I like what I hear today, what you're talking about adult day. You probably, Representative Balinsky, from his own experience. I can bring the name of Senator Prague, Commissioner Prague.
I hate to interrupt you, sir, but your time is up. And thank you for praising all of my colleagues. We appreciate it.
Thank you.
Are there questions from the committee? Seeing none, thank you. And thank you for your 4. You said 4, you have 4 adult centers.
Yes,
thank you for providing that service, because if they didn't have that outlet, we don't know what would happen, right? Absolutely. They would end up in long-term care facilities, most likely. So thank you for your service.
Absolutely. I appreciate it. Thank you.
Okay.
Up next, we have Holly Gedita Deming and Laura Hosch, I believe.
Good afternoon, Senator Miller, Representative Garibay, and distinguished members of the Aging Committee.
My name is Holly Jadita Deming. I
Yes,
am, no problem.
Well, how are you?
You may continue, madam.
I am the Director of Recruitment for iCare Health Network. iCare operates skilled nursing facilities with 11 located in Connecticut. We have over 1,600 licensed beds and around 1,700 employees. So thank you for this opportunity to testify in support of House Bill 5313. In 2021, in response to the dramatic staffing changes resulting from the pandemic, my company asked me to move from my role as licensed nursing home administrator to Director of Recruitment. As an administrator, I've been in the long-term care sector for 13 years and we've never seen anything like this before. iCare has complied with DSS wage enhancement program from last legislative session. And even with that wage enhancement program, filling open positions has been incredibly challenging. For background, the nursing home sector has been struggling to attract and retain nurses over the past several years, even prior to the COVID-19 pandemic. In 2019, iCare relied on staffing agencies to fill 17% of our licensed nurse shifts and around 3% of our certified nurses aide shifts. In 2021, this increased dramatically to 27% and 12%. This phenomenon occurred while our occupancy rates dropped from 92% in 2019 to 79% in 2021. Reliance on staffing agency increasing while occupancy is dropping is normally unheard of. We staff these positions to the occupancy rates. Our occupancy has now increased to 82% this month, so we imagine our reliance on agency is going to increase further. Agency billing rates have increased by nearly 35% for licensed nursing and 20% for CNAs at iCare, while Medicaid rates paid by the state have been flat for these types of costs. Severe staffing shortages caused by the elongated pandemic are hindering our admissions, increasing labor costs, and slowing the occupancy recovery for our healthcare centers, while the expanded use of nursing home staffing pool agencies are worsening the situation. A number of factors related to the ongoing pandemic explain the significant labor-related cost increases. First, the pandemic has destabilized and demoralized the healthcare workforce. Many have left healthcare in favor of a better paying work and less challenging non-healthcare environments. And new recruits have been very reluctant to come on board and take part in this critical, important work. We're frequently ghosted by new candidates during the interview phase of hiring. And a new infusion of resources and public policies is needed to bolster pay for these critically important healthcare workers. Many employees believe the slated 4.5% wage enhancements are lost to over 7% consumer inflation. Wages and other policies, such as tax credits and educational assistance for these positions, need to outpace inflation.
Ms. Gadita Deming, your time is almost up.
I will wrap that up quickly, just to say our company is literally forced to use nursing pool agencies in ever increasing numbers due to the staffing shortages. The pools are hiring away staff from the nursing homes to sell them back at many times the cost. As was discussed earlier, there's a lot of competition for that. And these rates are what we would really like to address and get under control for the whole industry. Thank you for this opportunity.
Thank you, madam. Are there questions from the committee? Seeing none, thank you for your testimony.
Thank you.
Up next, we have Laura Hosch, I believe, followed by Michael Werner.
Thank you, Senator Miller, Representative Garibay, Senator Fazio, Representative Wilson, and members of the Aging Committee. My name is Laura Hoch. I'm a Senior Manager of Advocacy with the National Multiple Sclerosis Society, testifying on Senate Bill 260. First, we want to express gratitude for this committee tackling this complex yet critical issue. The people of Connecticut are struggling, and this committee's willingness to address this speaks to your compassion and desire to support the residents of Connecticut. Multiple sclerosis, or MS, is an unpredictable, often disabling disease of the central nervous system, and upon diagnosis, a clinician will typically prescribe what is known as a disease-modifying therapy, or DMT, to modify disease course, treat relapses, and manage symptoms. Since the first DMT entered the market in 1993 at approximately $11,500 annually, costs have continued to rise. Now, with more than 20 on the market, the brand median is nearly $94,000 annually. 6 of the DMTs have increased in price more than 200% since they came on the market, and 9 are priced at more than $100,000 a year. Attached to my written testimony, you'll find a chart showing annual growth prices for DMTs for your reference. In 2019, the MS Society conducted a survey, and 40% of respondents reported having to alter the use of their DMTs due to cost by skipping or delaying treatment, taking less than prescribed, or even stopping treatment altogether. Because of the financial burden placed on people living with MS, many are forced to delay retirement or are less able to save and create a financial safety net for themselves as they age. 2 residents living with MS in the state have submitted written testimony about their own personal experiences, and I hope you're able to read that when you have a chance. A prescription drug cost control board, often referred to as a prescription drug affordability board, is one way that we could tackle this issue as a state. A strong board would be able to balance consumer affordability with the revenue needs of the suppliers. While we're thrilled that this issue has been raised, we do have a few concerns around the way the bill is currently written that could impact its effectiveness. So I've outlined in more detail in my written testimony some of our concerns. I just wanted to highlight a few. One being we want to clarify that we should be setting upper payment limits, not cost caps. We want to make sure that the board is given full authority to set these upper payment limits. We have concerns around the insurance commissioner having authority given his limited reach due to his jurisdiction. And we'd like to see stronger language around conflict of interest and board funding to ensure the board can fully address the issue in the state. Thank you again for all of your hard work on this issue. We hope to see the recommended amendments implemented so that we can build a truly powerful force in protecting the best interests of Connecticut residents.
Thank you. Are there questions from the committee? Seeing none, thank you for testifying before us today.
Up next, we have Michael Werner, followed by
we can't hear you. We can't hear you.
We have Michael Werner, followed by Tracy Wodach.
Hello. Good afternoon, Senator Miller, Representative Garibay, Senator Fazio, Representative Wilson, and other distinguished members of the Aging Committee. My name is Michael Werner, and I am the lead aging policy analyst for the Commission on Women, Children, Seniors, Equity, and Opportunity. Our commission wishes to express support for the following bills before you: Senate Bill 262, 260, 267, House Bill 5312, and 5314. Senate Bill 262 establishes a task force to study issues concerning homemaker companion agencies. This bill is timely, and it comes at an important juncture in Connecticut's rebalancing and Age Well initiative work. We are moving towards 70% of LTSS recipients receiving services in the community. We are teaching municipalities to create dementia-friendly neighborhoods and working hard to both have people age in place, but also to save taxpayers' monies as part of this deinstitutionalization efforts. This upper layer of infrastructure needs a fortified foundation to be able to serve our booming aging population, which will continue to demand more home and community-based services. The task force can help set the table for expectations and quality assurance measures to meet the investment being applied elsewhere throughout the system. Regarding Senate Bill 260, the Seniors Subcommission heard from many advocates and experts in the community who agree that a prescription drug cost control board could help add stability for medications during our current period of increased costs. Senate Bill 267 prohibits confusing advertising for homemaker companion services, which wrongfully imply health and medical services for work, which does not otherwise rise to that scope. The bill further adds an up to $1,000 fine per violation. Our commission heard from constituent complaints about this issue and hopes that this bill can help ensure clarity and accuracy for consumer employers in our state. HB 5312 shines a critical light on an important aspect of Connecticut's LTSS delivery model. Adult daycare centers in our state have earned their place of inclusion in the state Medicaid plan. They provide a myriad of services, including the presence of a licensed nurse and a low daily rate to help residents around the state. This bill would align with what's already permissible in New York and Massachusetts Adult daycares may even innovatively help bridge the gap for the shortage of home care workers that our state is currently facing. Lastly, in February, the Senior Fraud Task Force, which I help co-chair, transmitted its final report to the Aging and Human Services Committee. HB 5314 addresses mandated training for mandated reporters, caseload burdens for protective services for the elderly, disclosures for potential conflicts of interest by those assisting Medicaid applicants, and provides for a conspicuous written disclosure note advising Medicaid applicants of their legal rights. It encourages seeking out an elder law attorney if applicants meet certain criteria to ensure their finances and rights are protected. We appreciate the leadership of the Aging Committee, and thank you for allowing me to testify today.
Thank you very much, Attorney Warner. Are there questions from the committee? I just want to make a brief statement, comment. I want to thank you and your co-chair, Attorney Wilson, for the work that you did, as well as the task force for the work that you did on the senior fraud. And I think in our discussions, we know that there needs to be more work. More work has to be done around this issue. But I know that you met for months, and I know it was not a difficult task, but I think that the group came to a consensus of what was important to the aging population. So thank you for your report. I appreciate you taking the charge and making sure that we did end up with the product that we have. So I appreciate both of you. And I have to admit, there is some, in full transparency, there's a couple of tweaks that we need to make, and we're still working with you. So the language that we see today is not the final language of the bill. So again, we appreciate it.
Well, thank you very much too for your leadership, and we appreciate you and Representative Garibay and Senator Fazio visiting us during our work. And we look forward very much to seeing the final work product, and hoping to continue with the consensus building that we've had from the last year and bringing forward really great bills that help to protect our older adults. Thank you very much.
Thank you.
Up next, we have Tracy Wodach, followed by Mag Morelli.
Senator Miller, Representative Garibay, and distinguished members of the Aging Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I am also an RN with nearly 40 years experience. The Connecticut Association for Healthcare at Home is the united voice for our licensed home health and hospice agencies, as well as several non-medical homemaker companion agencies. Together, our members provide services that foster cost-effective home care for Connecticut's residents in the setting they prefer most, their own homes. I'd like to testify today on SB 261, 262, and 267. The association and its home and community-based providers support the intent of SB 261 as state income tax deduction for home health care costs. However, the term home health care is a finite group of skilled medical services provided by the licensed home health care agencies only. Most of this level of care is already covered by insurance, such as Medicare, managed Medicare, commercial insurance, and Medicaid. I believe the population that this bill would benefit would be the term home care, not home health care. This term would cover non-medical private duty care as well as home health care not covered by insurance. Regarding SB 262 to create a task force to study homemaker companion agency issues, perhaps there's a need to do this due to the rapidly expanding services provided in the community by homemaker companion agencies who are registered under the Department of Consumer Protection. I would hope a study or review of the current regulations for such agencies would reveal that the regulations need to be updated to truly capture the services provided by the homemaker companion agencies. These agencies have responded well to the evolving state-funded services under the various waiver programs, yet their regulations don't align with DSS initiatives. Should this bill pass, I would be honored to be part of the task force. Lastly, SB 267, prohibiting homemaker companion agencies from advertising provision of health and medical services and expanding the penalties, and is a case in point for my comments regarding SB 262. As more people age in place, the expertise needed to care for their needs, especially those with memory loss, requires a trained staff member to be able to support memory loss behaviors and decline. It's not medical, it's communication and an approach. Homemaker companion agencies should be able to support these needs in the community. Another example is the inability to use the term PCA in their advertising. PCA is an accepted role under the DSS waiver programs, yet not under the DCP regulations for homemaker companion agencies. Let's find a way to help the homemaker companion agencies do what they should be providing for services to meet the needs of our Connecticut residents. Finding ways to expand penalties is not the way to accomplish this. I'm happy to also work with DCP in collaboration with DSS and DPH to help move these opportunities forward, not backward. Thank you for the opportunity to provide testimony on these bills.
Thank you, Ms. Wodach. Representative Hughes.
Thank you, Madam Chair, and thank you, Tracy, for your detailed testimony. I assume you submitted written testimony about the language that you first talked about updating from home health care to home care.
Yeah, I did submit my written, but simply I think it just needs to say home care, which is a more comprehensive view of the services provided by both types of agencies, home health and non-medical home care agencies.
Yeah, and I appreciate that, and I appreciate the intent and collaborating to we're trying to educate the public as well, and I think that's what Senator Miller spoke to earlier in the testimony, that the public doesn't understand what kinds of services they are hiring and the scope of that service, and they just get a standard contract or whatever, and they're not clear of what those limits are and what kind of agency they need to be hiring. My question to you is, how can we future-proof this so that we're not coming back a year from now and saying, now we need to update it to describe this broad scope of service?
Well, I think maybe we should just look at what the definitions are that exist for home care agencies. If we make sure that those are inclusive of both home health care agencies, licensed home health care agencies, and DCP registered non-medical home care agencies, homemaker companion agencies, then I think we probably would cover that. Because I believe you're looking to allow the deductions for agency-based home care. Am I correct? If people are paying out of pocket for agency-based home care, whether it's non-medical, homemaker companion, PCA, or it's a home health aide with maybe a nurse coming in to assist once in a while, but not covered by insurance. That's
Right.
what I believe you're looking to cover, correct?
I believe the Senator Miller, do you have the specifics on this?
I'm going to have to ask. Marie, are you on? She's not here, so that's my understanding. That's my understanding.
Yeah, I believe Senator Kelly raised a similar bill that was before labor, I believe. And I submitted similar testimony.
Sorry, what was the question, Senator?
The tax bill.
Yes.
Tax at 261. She wanted to know if it encompasses all healthcare agencies services, home care services, and not just the nursing.
I believe it's home health and homemaker companion agencies.
Yeah.
But not home care. That's the difference, right, Tracy?
No.
Well, no. The bill, I think, currently says home health care. I just want to make sure that it does incorporate what Marie just said. It should include home health care and non-medical home care.
Yes, it does.
Okay, great. So she's suggesting that change the name to home health. I mean, home care as opposed to health, right?
More comprehensive, yeah. Or just ensure the definition covers both.
Okay, yeah, we can change the title pretty easily. I think it was home care to begin with, actually, but
and then change it to home health.
Or maybe maybe just adjust the definition within the bill, and I think we probably would have it covered.
Okay, we'll take a closer look at it. So thank you for your suggestion.
And just
Thank you,
finally,
Marie.
if I may, Madam Chair. When you said you would be happy to collaborate with DCP, do you have suggestions around this, like maybe outreach campaign we can do to families, we can do with families out in the public who are not sure what they are looking for and what they need and how to engage in that process?
Yeah, I think if we work with DCP, there can be a lot of collaterals created to help educate. As we work, our association supports primarily the licensed and certified home health and hospice, but we also work with some of the DCP registered homemaker companion agencies. The Home Care Association of America also has a large membership of the DCP registered homemaker companions. So I think it would be beneficial. They've met with DCP. I've had some conversations with DCP. I think if we're together on it, we can probably get to where we need to be. The regulations, unfortunately, as I mentioned in my testimony, the regulations for DCP really are a bit limited. And that's where we need to enhance them, because currently agencies aren't allowed to advertise PCAs because a PCA is not defined within the regulations, but Department of Social Services recognizes PCAs as a very valuable role that the agency-based homemaker companion agencies fulfill the services for. So that's a piece. And then the other piece that's really big is the whole memory loss piece. Those that need supportive care in the community, long-term services and supports, and may not need medical care from a nurse, but need someone to be in their home as a companion, as a caregiver, as someone to support their personal care needs. It's important for that level staff to understand how to communicate and how to provide the services for people with memory loss, because there's a large population of those with memory loss living in the community. Currently, DCP is stating that they're not allowed to advertise that they have staff trained to provide services in memory loss because they feel it's too much of a medical orientation to care. When they're not saying dementia, they're not saying Alzheimer's, they're saying supportive memory loss care. So I think we just need to try to find the right language that is acceptable under the DCP regulations. And as I said, Home Care Association of America and our association have both been working with DCP. I just think we need to make sure it's more clear as to what they can do. I hate to see the homemaker companion agencies be told they can't do something when we're really moving to the future of more and more people in the home and more people needing services by homemaker companion agencies.
Great, thanks, Madam Chair. I'm good.
Thank you. Are there any other questions? No, thank you, Ms.
Thank you so
Wardell.
much.
You're welcome. Mag is next.
Thank you, Senator Miller. I'm Representative Garibay and members of the committee. My name is Mag Morelli, and I'm the president of Leading Age Connecticut, a membership association representing the not-for-profit provider organizations serving older adults across the entire field of aging services and senior housing. Leading Age was pleased to actually submit testimony on several bills before you today, and I want to speak to just a few of them. First, on House Bill 5310, an act requiring nursing home facilities to spend at least 90% of their Medicaid funding on direct care. Leading Age Connecticut respectfully opposes this bill for a few reasons. The first is that the bill would require that each nursing home summarize their annual cost report for the purpose of public disclosure on the DSS website. We don't oppose the concept of transparency, but all the cost reports are already posted, and if summaries are to be developed for disclosure purposes, we would recommend that the department do it in a manner that applies an equalized method of summarization for each cost report. We also oppose the requirement of the 90% of the Medicaid funding to be spent on the provision of direct care. I think many people spoke before me. Connecticut has a cost-based nursing home rate system, and by its very nature, if done correctly, the cost report system establishes a Medicaid rate that is calculated using only state-defined allowable costs. As proposed, the bill would exclude costs critical to providing quality resident care, such as heat, utilities, food, housekeeping, social work, physical therapy, occupational therapy, nutritional counseling, recreation therapy, and others. So there, as written, it is much too restrictive, and it wouldn't be in the best interest of the nursing home residents. On House Bill 5311, we have no objections to this bill that would encourage socialization for nursing home residents by providing transportation for visits. And we just want to mention that we appreciate the attempt to provide financial support to facilitate that effort. 5312, an act concerning the adult day services. We absolutely strongly support this bill. You've heard from several adult day centers today. We have many in our association, and we strongly support this bill before you. And House Bill 5313, an act concerning price controls on services provided by temporary nursing service agencies. We support this proposal, which would establish a level of accountability and regulation of the temporary staffing agencies that are servicing the nursing home sector. We would encourage the committee to consider expanding the scope to such agencies that service other healthcare providers. We've provided a lot of testimony on those bills and a few other bills, and we just want you to know that even though some of these are testimonies in opposition to the proposals, we're always willing to work with the committee to achieve a balanced approach to these policy changes. And we thank you for taking our concerns into consideration. So thank you. I'd be happy to answer any questions.
Thank you, Meg. Are there questions from the committee? Seeing Mac, thank you. And I want to thank you for your cooperation and working with the committee on bills that would benefit both sides of a issue. So I appreciate it.
You're welcome. Thank you.
Up next, we have Kristen Whitney Daniels, followed by Donna Spellman.
Good afternoon to the chairs, ranking members, and distinguished members of the Aging Committee. My name is Kristen Whitney Daniels. I'm the chapter leader of T1 International's Connecticut Insulin for All, a group of volunteer advocates raising awareness about insulin pricing and fighting for affordability in Connecticut. I think in this context, it's really important to note that we do not accept any pharmaceutical industry funding or any funds that would compromise or influence our ability to advocate. I'm also a Shelton resident who lives with type 1 diabetes and other chronic illnesses. I'm testifying today in support of Senate Bill 260, an act concerning a prescription drug cost control board, while asking for some improvements. A PDAB represents true transformative policy for Connecticut residents. For people with diabetes and other chronic illnesses, a PDAB with the authority to institute upper payment limits, and to be clear, that's not price controls, would be monumental, an opportunity to finally start addressing the root cause of the drug pricing crisis. I'd like to refer the committee to my written testimony for some technical details, but today I really want to focus about insulin and one of pharmaceutical manufacturers' most egregious examples of greed. It's no secret that insulin is the poster child of the drug pricing crisis, and it's for good reason. We're celebrating 100 years since the discovery of insulin, yet companies continue to price gouge patients. Patients have no choice when it comes to insulin. I either buy insulin or I face an excruciating death. In response to testimony that prices haven't fluctuated, since the 1990s, the price for insulin has risen 1,200%. Yet the estimated cost to manufacture a single vial of analog insulin is between $3 and $6. Out-of-pocket spending on just insulin for people with type 1 diabetes nearly doubled from 2012 to 2016, increasing from $2,900 to $5,700. Manufacturers have no problem selling insulin to Canada or other European countries at half the price or less. They will still sell to the US at a profit with a PDAB. And there are already serious access issues here that the drug companies allude to, but it's because of a lack of access. A Yale study found that 1 in 4 patients with type 1 diabetes have had to ration their insulin. I am one of those 1 in 4. I will never forget the day I went to the pharmacy to be told that my 1 month supply of insulin would cost me $2,400, and that's with insurance. I frantically searched for every solution and was denied every avenue of help, including Novo Nordisk prescription assistance programs, which they love to tout as a solution. I was one of the lucky ones. I found assistance, but many diabetics die waiting for solutions from manufacturers. In response to the crisis, they've told us that it's a shame people have lost their lives, but there's a complex system at play. They point their fingers, refusing to acknowledge their part and complicity in the crisis. No one is willing to take a cut in their millions of dollars in profits. Connecticut has been a leader in diabetes legislation, and now Connecticut has the opportunity to create the strongest PDAB in the country. This is why we ask that the committee consider and implement proposed changes to lead the country in this legislation. And I'll refer the committee to my testimony that I've submitted, which includes the suggestions along with an attachment with proposed bill language. We'd like to thank the co-chairs for raising this potentially monumental bill, and I welcome many questions. For too long, Connecticut residents have had to bear most of the burden of our health system's inequities. If patients can't access their basic medications to live,
Ms. Daniels, your time is up.
Thank you. No amount of innovation matters. And so this is why I recommend the bill with the changes. Thank you.
Thank you very much for your testimony. Representative Hughes.
Thank you, Madam Chair, and thank you, Kristen. Good to see you again as we continuously work together to improve Connecticut for all people. But I especially want to thank you for giving some scope that it's not just aging that this is for, and of course we're all aging all the time, but that these conditions, I don't want to call it disease, but life-threatening conditions can happen at any age, and that we need to start with the most vulnerable, protect them, and go from there before we protect the profiters of the life-saving drugs. So thank you for your testimony, and I will look very carefully at your written testimony for improvement in the language to make sure this is the strongest possible legislation we can put forth this session.
Thank you, Representative Hughes.
Thank you, Kristen. And I want to say thank you for your advocacy. I have a family where we're predisposed to diabetes, so I definitely know how important it is to have insulin, affordable insulin. And I've seen the prices go up because it started with my grandmother, right? So, and to see what the prices is now, it's unbelievable. So again, thank you for your advocacy and your group as well, the organization that you belong to. We appreciate it.
Thank you.
Up next, we have Donna Spellman, followed by Joan Wilson. Ms. Spellman, are you there?
Sorry. Yes, sorry about that. Good afternoon, everyone. Good afternoon, Senator Miller, Representative Garibay, members of the Aging Committee. I'm Donna Spellman. I'm the Executive Director of River House Adult Day Center, a nonprofit health-based adult daycare center located in Greenwich, serving the Greenwich and Stamford communities. I also serve as on the executive committee for the Connecticut Association of Adult Day Services. You heard from my colleagues, so I won't get into all the technical of what we do in adult daycare. You heard from many and you're still going to hear from more, but I want to thank you for the opportunity to speak in strong support of House Bill 5312, an act concerning Medicaid coverage for adult daycare services and transportation to and from our centers. When the world shut down due to the COVID-19 pandemic, adult daycare centers throughout the state kept moving forward. Many of us shifted to remote services, but only for a very short time. As an association, we worked together to create best practices so that we could safely reopen and care for the families who desperately depended on us. I am extremely grateful to report that as an association, we have never ever had a COVID spread in any of our 38 adult daycare centers throughout the state of Connecticut. People ask us why we were so determined to reopen our on-site centers so quickly, and our answer is really simple. Our families depended on us. In my center, we saw the rapid decline in those who remained at home for only 3 short months. Those with dementia became even more confused. Their caregivers experience burnout due to increased stress and a lack of much needed respite and support. In my center, sadly, we lost 4 clients and 3 caregivers during that short 3-month period of time. That's a number that we have never experienced before and hope that we will never see again. And important to note is that none of those individuals died because they had COVID directly. Their families tell us that their declines in health were associated with social isolation, lack of physical and cognitive stimulation, lack of in-person nursing care, depression, anxiety, and extreme stress. In short, the absence of in-person adult daycare services became a question of life and death. Coming to terms that a family member requires extensive daytime care is an emotional situation. Asking for help takes courage. The moment that someone needs our help is the moment that we need to embrace them and welcome them to our centers. We need people who are on Medicaid to be able to access our help when they need us, not only if they are currently assisted through Medicaid waiver programs. Understanding the extreme need by our most vulnerable population, I hope that you will give strong consideration to include adult daycare as well as transportation in the Medicaid plan moving forward. I thank you so much for your consideration and for being on this for 3+ hours. You are all an amazing committee. Thank you.
Thank you. Are there questions from the committee? None. Thank you for your testimony today and also for the work that you do with our older adults. We appreciate it.
Thank you.
Up next, we have Joan Wilson, followed by Lee Cantor.
Good afternoon, distinguished chairs, ranking members, and members of the Aging Committee. My name is Joan Reed Wilson, and I'm here to put my full support behind House Bill 5314. I'm an elder law attorney and have been practicing law since 1997. My main areas of practice include elder law and Medicaid planning. I'm currently the president-elect of the Connecticut chapter of NALA and a member of the elder law section of the Connecticut Bar Association. And I also recently served as the co-chair of the task force to protect senior citizens from fraud. House Bill 5314 incorporates the results of the task force report presented to this committee last month. The one specific charge of the enabling bill that created the task force was to study planning services related to Medicaid applications. The process of applying for long-term care Medicaid services is complex and involves a multitude of laws, rules, and regulations that include protections for consumers. Yet these complexities are not necessarily understood or appreciated when an individual applies for Medicaid by both lay people and professionals who work in the elder care field. So these protections are often overlooked to the detriment of older adults and people with disabilities. The task force learned through testimony from a variety of professionals that the reason for this is twofold. One, there is no central location for applicants to seek assistance, and the various application assisters do not have mandatory or consistent training. And two, the applicants themselves do not have a full understanding of their rights to know when they should seek legal assistance. Improper guidance not only potentially impedes the consumer's rights, it also can ultimately cost the state more. In my practice alone, I've heard from multiple clients that were told by a non-attorney application assister that they don't qualify for the Connecticut Home Care Program for elders because their monthly income is too high. Yet Connecticut has an established relationship with the Plan of Connecticut to set up pooled trusts to handle excess income. Without this proper guidance, vulnerable residents of our state may go without the care they need, or they potentially might spend all of their funds on the care they need and then be forced to transfer to a skilled nursing home with the state footing the bill. In the long run, this all costs the state more money. These are legal safeguards set by federal and state laws that some of our most vulnerable populations are not afforded. As part of our discussion, it was clear that even some professionals do not have a full understanding of the details of these legal rights. And even The seemingly simplest fact pattern might cause complexities in a Medicaid application that, if not addressed, could cause the applicant to spend down necessarily to the detriment of their loved ones and forego their protected rights. The
Ms.
solution,
Wilson, your time is almost up.
okay, thanks. The solution is to ensure that all Medicaid application assisters provide and review a straightforward and clearly written disclosure that the applicant may have legal rights to protect their assets prior to applying for Medicaid. This disclosure would not require an applicant to seek legal counsel. It just provides them with the information that they may have legal rights that they want to protect.
Thank you. Before I ask for questions from the committee members, I want to thank you, and I thank Michael for the work that you did on the task force as co-chair, and as well as the other members of the task force. And I know there some tweaking that we have to do, as I stated to him, that I'm waiting for some information so that we can make the language stronger. But thank you for the report that was submitted to the committee, and we really do appreciate the work that you did. Are there questions from the committee? Seeing none, thank you again, Attorney Wilson.
Thank you very much.
Up next, we have Lee Cantor, followed by Denise Cesario.
Senator Miller, Representative Garibay, and distinguished members of the Aging Committee. My name is Leah Cantor, and I really appreciate the opportunity to testify in support of Raised Bill 262. I am the daughter of a brilliant theoretical physicist. Sadly, in my dad's later years, he developed dementia and ultimately required 24/7 live-in caregiver. Our family engaged a well-known franchise of a national home companion agency to provide this care in his home. One day, I made my first unannounced visit and found my dad home alone. He didn't acknowledge me as usual and appeared drugged. Soon after my arrival, the caregiver returned and apologized for leaving him alone. My dad was disabled, minimally verbal, and couldn't walk without help. He could, however, rise from a sitting position by himself, but would fall without aid. The caregiver was not permitted to leave the premises without submitting a request to the agency and waiting for relief. Given the opportunity through the court to provide documentation of that request, the agency chose not to. The agency also failed to report the elder abuse to DSS as required by law as mandatory reporters. In Connecticut, elder neglect is elder abuse. The agency owner actually told the police, "I was aware that the caregiver was leaving my dad home alone," and claimed that he didn't report the incident because there was no abuse. This couldn't have been further from the truth. To date, not one state agency has taken any accountability for the agency owner's failure to report the abuse. Documentation supports strong allegations that the caregiver left my dad home alone dozens of times. Consequently, I filed a lengthy complaint with the DCP with pages of serious allegations, many of them substantiated through the investigation. The DCP then audited the agency and reported 16 regulation and statute violations. They reported that not one complete file that they audited had been fully vetted, reviewed, or signed by the agency, including Homeland Security checks, reference checks, among many others. The magnitude of this is enormous. The DCP then issued a letter of correction. 2 years have passed, more complaints were filed against this agency, and they continued with their pattern of violations. Not until this past August did the DCP issue an AVC, Assurance of Voluntary Compliance, in which the agency promises to be compliant. It included a $9,000 fine that the DCP claims is a voluntary settlement and is not a conclusion of law or admission of guilt, liability, or violation. Without clear-cut policies regarding consequences of violations, this is as good as a pinky swear and has proven as such. In just 4 months after the AVC was signed, it appears the agency has violated it multiple times. So at what point is enough enough?
Ms. Cantor, your time is almost up.
Okay, thanks. I have spent 3 years seeking answers and accountability and have gotten a stifling education. I learned the following. Home companion agencies are encouraged and not required by the DCP to maintain compliance to Connecticut statutes and regulations. The DCP does not provide oversight for quality of care for home companion agencies. My dad did not receive one unannounced visit in 9 months from the agency to check on him. Though not required by law, it is reasonable to expect at least one visit in 9 months. In fact, the DCP reported that the agency neglected to properly and sufficiently supervise its staff. I have lots more. You can read it on my written testimony. I know I'm out of time, but this is serious stuff. And I'm really excited that there's a task force to examine all these things. We can do better than this. So I thank you for your time.
Thank you, Ms. Cantor. Are there questions for Ms. Cantor? Seeing none, Ms. Cantor, I want to personally thank you for your advocacy on this issue. I think it is important that we have a task force to look at this industry, especially since our state is aging. And so again, thank you very much. Appreciate you coming to testify before us today.
Up next, we have Denise Cesario and Ashley Van Meter.
Good afternoon, Senator Miller, Representative Garibay, and distinguished members of the Aging Committee. My name is Denise Cesario. I am the Executive Director of Elder House, a not-for-profit adult day center in Norwalk, serving the towns of Darien, Norwalk, Stamford, New Canaan, Westport, Weston, and Milton. I am speaking today as a direct provider of adult daycare and as a member of the Connecticut Association of Adult Day Services, of which I am an executive member. I apologize for any redundancy. I know my colleagues spoke ahead of me. Please know how passionate we are about our work and our belief in adult day services. I thank you for the opportunity to speak on House Bill 5312. Never in my 30-year career, I've been an executive director of Elder House for 30 years, have adult day services been as more vital than they are now as we shore up community-based services needed to protect our frailest older adults post-COVID-19. Throughout the pandemic, Connecticut's most vulnerable older adults, those with multiple chronic conditions, continue to be cared for in adult day centers across the state. The staff at these centers went to extraordinary measures to keep their doors open and clients safe. It is a critical time to provide community-based services for those clients and allay their frightened fears of placement in long-term care facilities. Across the state, a strong network of adult day centers is vital to improving health outcomes for aging adults and keeping them in community-based care. Adult day staff have a proven record of success in disease management, delaying further decline. For medical model centers, because a nurse is on staff to monitor daily health conditions of the clients under her care, early detection is possible, leading to better outcomes. Early detection reduces costly trips to the emergency room, hospital readmission rates, and premature placement in skilled nursing facilities. An example of this, a diabetic client who is showing signs of dangerously low sugar levels while at the center. On-site early intervention by a staff nurse can take place. It can reduce the chances of a diabetic shock, which can lead to life-threatening complications, and certainly prevent a trip to the emergency room. Not only is community-based care cost-effective, but it is also recognized as the care option older adults want most to stay living in the community. And the ability of adult day centers to offer care in a social setting is icing on the cake. Adult day centers foster an environment of inclusivity and enrichment through activity. Despite cognitive and physical limitations, older adults look forward to their days with friends participating in meaningful activities at the center. Engagement and socialization are vital to the well-being of older adults. At Elder House, 25% of our clients are 90 years or older, and yet they attend up to 5 times a week because Elder House adds so much joy to their lives. These services are so vital to our aging community, and that's why I support access to adult day services for the inclusion of Medicare patients. As Senator Miller had previously pointed out earlier, there is a group of low-income older adults on Medicaid with
Ms. Cesario, your time is almost up.
Thank you, with chronic medical conditions who are left out of access to adult day services. With no financial resources, most of these individuals will eventually end up in a nursing home. So on two fronts, this makes no sense. Certainly financially, $74 versus $250 a day for nursing home makes no sense. But most importantly, quality of life. Older adults deserve every opportunity to stay living in their homes and sleep every night in their own beds. Thank you for the.
Thank you, madam. Are there questions for Denise? Thank you very much for testifying before us today, and especially the work that you do for our aging population, our older adults. Thank you.
Thank you.
Up next, we have Ashley Van Meter, followed by Christy Cavell.
Hi there. Thank you for letting me testify. My name is Ashley Van Meter. I'm from the Association for Accessible Medicines, and I'm testifying on the Drug Affordability Board that was being discussed a little earlier. We just wanted, as the representatives of the generic and biosimilar industry, to discuss the importance of generic medicines within the state of Connecticut in ensuring that patients that need affordable medicine have access to the medicines that they need. Last year alone, the generic medicine saved the state of Connecticut $4 billion. I don't really need to take a lot of time. The particular bill that is before you, we have negotiated in many other states with NASHP and other stakeholders to have this sort of legislation in those states. Right now, there are 5 other states where the Affordability Board bills have passed and they have them into law. Maryland is the furthest along. The one thing that I would say is it's very important to distinguish brands versus generics with the type of triggers that are put in place for being brought in front of the board so that you're actually getting the medicines that are driving cost in your state. And as for the generic portions of the bill, we feel you do have the right triggers with a $100 WAC or wholesale acquisition cost plus 200%. In that situation, you're going to get, the folks that are in fact driving cost in the system instead of more affordable generics that could cost pennies on the dollar. Many generics generics are about 90% and only 20% of the cost, with our co-pays for patients on average around $6 opposed to $56.98 for brand co-pays. So I think it's great that you all have distinguished that generics are actually helping the system save money and ensuring that patients are not deprived of medicines that they need because they cannot afford them. And with that, I can stop, and I'm happy to answer any questions about the generic industry and our feelings about the bill.
Thank you very much. Are there questions from the members on the committee? Seeing none, Ashley, thank you very much for testifying before us today.
Thank you very much.
Up next, we have Christy Cavell, followed by Mark Anthony Galucki.
Good afternoon, Senator Miller, Representative Garibay, and members of the Aging Committee. My name is Christy Koval. I'm the Director of Public Policy for the Alzheimer's Association Connecticut chapter. I'm here today to lend our support on 2 bills before you today. The first is 5312 for adult day services. As you know, there are now about 80,000 people in Connecticut who are living with Alzheimer's disease. We estimate this number is going to rise to 91,000 just in a few short years in 2025. Connecticut is the 6th oldest state. And as we continue to enrich and enhance our home and community-based services, I want to talk a little bit about adult day services. When people call our helpline and they are looking for options, for care options while they're caring for their loved one at home, adult day centers provide that. They provide socialization, activities, medical services, transportation, and to see that these centers, we've gone from 50 a few years ago down to 36. This is not trending in the right direction. We'd like to see more of these centers, more options for these folks. And as we saw with the COVID-19 pandemic, the social isolation was a real problem for our folks who are living at home with Alzheimer's or another dementia. So enhancing the opportunity for adult day services to be part of the state Medicaid plan is something vitally important. The second bill I wanted to talk about a little bit is Senate Bill 266. And as many of you know, due to the progressive nature of a person with Alzheimer's disease, they are at increased risk for abuse or neglect. Oftentimes, not being able to balance the checkbook or having difficulties managing finances is often one of the first things that presents themselves. And given these cognitive challenges, a person living with Alzheimer's or another dementia is at risk, increased risk for abuse, including financial exploitation. So we do support increased transparency with a registry regarding individuals who have committed a financial crime against an older adult. This will help provide necessary safeguards for families who may be needing to hire somebody and want some more information around who they're looking to hire. And I'm happy to answer any questions about the two bills I've spoken about today. You do have my written testimony, and I thank you for the opportunity to come before you today.
Thank you. Representative Belinsky.
Thank you so much, Madam Chair. And thank you, Christy, for again testifying on these bills. For members of the committee that might be newer, both of these bills have been through our committee and have passed our committee on several other occasions. So what we're doing is we're trying to support these very, very important aging in place and protective resource opportunities and get the decision making back into appropriations in a year where hopefully the resources to be able to assist these important services might be available. So I am already co-sponsoring both of these measures, and I have no questions other than what's taken so long.
Maybe this is the year they'll get across the finish line. Thank you, Representative Belinsky.
Thank you, Representative. Are there any other comments or questions from the committee members? Seeing none, Christy, thank you and your organization for the work that you do.
Thank you.
Up next, we have Mark Anthony Galucki, followed by Chrissy Shattini.
Hello, good afternoon. I'm Mark Anthony Galucci, and I'm a Chief Advocate at the Center for Disability Rights, one of Connecticut's 5 centers for independent living. And I'm here to testify on 5311, 5314, 261, 264, and 265. I've written extensive testimonial here, so I'm not going to go through it. I just want to skip through it. 5311, an act concurrent socialization by providing transportation. We are very much in favor of this, but we don't like the way the bill was written. We think the language about providing a ride within the municipality that the skilled nursing facility is in is not expansive enough and very impractical, because most people have family and business outside of the town. And in my local area, Jewish Senior Services is located in Bridgeport on Park Avenue. And the irony of this is that they would be mandated to give a ride 3 miles away, another part of Bridgeport, but not across the street into Fairfield. So we need to look at that and change that, and also encourage somehow legislation there, some language about having the skilled nursing facility facilitate rides on the ADA paratransit and the dial ride. On 264, and that concerning qualified deduction for Medicaid applied income, we support this. We concur with the testimony submitted by other folks here. I have a lot of battles with DSS workers all the time who try to claim that a payment into a pooled trust, or a payment for long-term care plan, or a payment for a conservator, or whatever is somehow an unauthorized transfer. This is
Hi, Paul, it's Dawn. I just wanted to let you know you'll be the last
Excuse
one.
me, thank you. I'm sorry, you may continue, sir.
Okay, thank you. I thought I ran out of my 3 minutes already. So I think we need to do this. We're in favor of that 265 notice of staff to patient ratios. We're mainly interested in the telephone access part of that. And that particular, we believe very strongly that people have a right to have communication with the outside. The amount of money that people in nursing homes are allowed to keep each month is not enough usually to pay a phone bill. And we don't think that phones in common areas are going to do the trick because they're not accessible and the staff typically restricts use of them. Finally, 261, and that considering concerning the state income tax deduction, we're all on board with that. This could be a game changer. If we're serious about keeping people in the community and helping them age in place, this is a no-brainer. The idea of family taking more responsibility for the care of their loved ones instead of shifting that responsibility to state is an excellent one, and we ought to pursue that. And we think the state will actually save a lot of money because less people are going to nursing homes.
Thank you for your testimony, sir. Are there questions from the members? Seeing none, thank you for your testimony.
You're welcome.
Up next, we have Chrissy Schettini and Paul Listro.
Good afternoon. Good afternoon, Senator Miller, Representative Garibay, and members of the Aging Committee. My name is Chrissy Schettini, and I'm the Program Director for Complete Care's Palace Adult Day Center. I'm testifying today on behalf of the Connecticut Association of Adult Day Services, and we are here to speak in support and testify in strong support of House Bill 5312 regarding Medicaid coverage for adult day services. As you've heard from my colleagues today, we'd like to be able to offer adult day services as an option for Medicaid recipients. Our services are not currently covered by the Medicaid state plan. Right now, the service is limited to only home care program waiver recipients. Many states' Medicaid plans do offer adult day service, and not only does it give an additional choice for seniors who have need for supervision and care, but it also saves these states money on more costly long-term care services. Personally, I'm a huge advocate for adult day service as I've been in this industry over 15 years. In that time, my company has operated several adult day programs in other states such as Massachusetts, and I also serve on the board of directors of NADSA, which is the National Adult Day Service Association. So I'm in a unique position where I've seen the benefits and life-changing impact of adult day services for the older adults and the cost-saving effects for states who offer these services to their Medicaid recipients. In fact, I was surprised when I came to Connecticut and learned that this service was not available for Medicaid participants as a choice. You've heard today the rate of reimbursement for our program is $74.74. This rate includes a full day of supervision, door-to-door transportation, nursing services, personal care services, activities, exercise, 2 meals per day, and many more, all while allowing seniors to remain at home and go home at night, being part of their community. Some of them live with families, others live alone in senior housing, where coming out to our program is their only interaction. Our program staff are fully trained. They monitor clients' health, communicate with doctors. The folks we care for have chronic conditions like Alzheimer's, dementia, diabetes, Parkinson's. Some folks have mobility issues, need assistance with ADLs. Without the adult day services, many of these clients would very likely need nursing home placement or full-time home care. Our programs prevent and delay placement in nursing facilities, sometimes for years. Also, we help to prevent the need for expensive healthcare trips to the emergency room and acute care hospitals. Our staff are very often the first to notice a change in the client's health. We report it to their doctor, to their family members, and we're able to provide intervention that can be life-saving. By keeping these clients safe on a daily basis, we're creating long-term savings for the state, and this bill would help us to do that for even more Medicaid recipients. This can be seen through standard research and is backed by the Genworth Cost of Care Study, which you can find in my written testimony. But as a brief example, in Connecticut, from 2021, the data shows that the cost of home care, 40 hours a week, is about $5,000 a month. Nursing home placement, over $10,000 a month. Yet adult day services for the same amount of time, 40 hours per week, $1,800 a month. As Senator Miller pointed out, $250 a day for a nursing home versus
Ms.
$74 a
Schettini,
day.
your
Yes.
time is up.
at our program. Okay, I'm sorry. In conclusion, we'd just like to thank you for this opportunity to provide testimony and to thank you for supporting Adult Day. We would like to work with you and DSS to better understand the impacts and cost savings, and you'll find written testimony to support our service and to describe fully what we can offer for this low price. We implore you to allow this service to be added to the Medicaid state plan so that we can offer Adult Day to the Medicaid recipients in the state of Connecticut. Thank you so much, and I apologize for going over my time. We're just very passionate about this bill, and we really appreciate your help.
Well, thank you for your passion. Are there questions from the committee?
I'd be glad to clarify any of the earlier questions if needed.
I think they were answered. So
Okay.
Thank you. Appreciate your work. We need people like you and members of your organization in our communities to keep our elderly in our communities. So thank you very much.
Thank you.
And finally, we have Mr. Listro.
Good afternoon, Senator Miller, Representative Garibay, and to the distinguished members of the Aging Committee. My name is Paul Listro. I'm the CEO of Manchester and Vernon Manor, two skilled nursing facilities in Manchester and Vernon, Connecticut. Thank you for the opportunity to testify in support of House Bill 5313, an act concerning temporary price controls on services provided by temporary nursing service agencies. As providers in the long-term care industry, we are suffering to staff our buildings to meet ever-growing number of hospital discharges. Ever since the pandemic started, staffing in nursing homes has been affected negatively. In order to make up for the dearth of staff, providers are tapping into networks of staffing agencies who provide temporary help. For decades, our facilities have staffed successfully without the need to utilize resources of staffing agencies. We attracted, trained, challenged, and developed our own staff. The pandemic has changed that dynamic. Every day, we are seeking additional staff via the agencies. The agencies are taking advantage of our need by gouging the industry with unsustainable fees for necessary staff. I'm in support of HB 5313. 5313 would require the Commissioner of Social Services, in consultation with the Commissioner of Public Health, to establish maximum rates nursing pools can charge nursing facilities by type of nursing personnel. For the period September 15th, 2022, and ending June 30th, 2023, the rates per hour could not exceed $30 for a registered nursing assistant, $45 for an LPN, and $60 for a registered nurse. The bill has many details to address the egregious practices of the staffing agencies. It specifies composition of rates. Bill requires rates to include a reasonable administrative expense. Starting July 1, 2023, nursing pool agencies would be required to submit DSS annual cost reports. After July 1, 2024, the Commissioner shall consider annual cost reports provided by nursing facilities to the Commissioner pursuant to Section 17B-340 of the General Statutes when adjusting maximum rates nursing pool agencies may charge facilities for nursing personnel. For these reasons, I'm urging adoption of HB 5313. We do recommend accelerating initial rate limitations as follows. For the period July 1, 2022, or upon passage of the Act, whichever is earlier, and ending June 30th, 2023, we would recommend the rates be set in statute, $30 for a CNA, $45 for an LPN, and $60 for an RN. Allow me to go off script for a moment. Nursing facilities are stewards of the Medicaid dollars that the state distributes to all nursing homes. Because of nursing agencies, we are using those Medicaid dollars as inefficiently as you could possibly imagine. We have no control over what we're charged, yet hospitals are encouraging us to take patients, but we can only take patients when we have staff. We need your help.
Your time is almost up.
This is a temporary measure for a short period of time, but we need your help. Thank you again for this opportunity to testify in the bill. I would be happy to answer any questions.
Thank you, Mr. Listro. Are there questions from the committee members? Seeing none, thank you for your testimony.
My pleasure. Thank you.
Well, we've reached the end of the list of those individuals from the public who signed up. Is there anyone who would like to testify and didn't have the opportunity to sign up? Seeing none, we've reached the end of this public hearing and I adjourn it for this evening. I want to thank I should say this afternoon. It feels like evening with the sun that seems to be going down now, but I want to thank the members for attending the public hearing and staying with us all day. So both my co-chair and I really do appreciate your participation. Have a nice evening, everyone.